Okay. So, first of all, thank you ever so much, Seth, for the introduction, and a very big thank you to NANSIG for inviting the BSNR to do this careers webinar with you. And also, of course, I should thank all of you in the audience for actually giving up a bit of time on your Saturday morning to hear about our specialty. We've got a fantastic lineup of speakers today, all of whom I know are enthusiasts about neuroradiology and the careers that they've come into, and I think are very keen to tell you about their areas of work. So we've got quite a packed lineup for this morning. The programme shows you the various speakers we've got talking about the different areas of neuroradiology that they practice in. I'm not going to go through the programme now. I think the speakers will probably introduce themselves as they go along, but we are covering pretty much the whole breadth of the specialty of neuroradiology. Now, just before we go over to our first speaker, I just want to say a little bit about the entry into neuroradiology as a specialty. I know that some of the speakers are going to talk about their own interest areas and how you can get into those interest areas and the routes that they took. But I just want to give you a little bit of a general overview, just so that a good sort of basic understanding of the pathway to neuroradiology. You all have an interest in neurosciences, I guess, as you're part of NANSIG. But obviously the route into neuroradiology is very different from the route into neurology or neurosurgery, because the route to neuroradiology is via clinical radiology. And so if you want to become a neuroradiologist, the way to do it is to look at the training in clinical radiology first. Now, there's a lot of information on the Royal College of Radiologists website about how to get into radiology training. And I would urge you, if you're neuroradiologist career, to visit the Royal College's web pages. There's a whole section on careers and recruitment in the clinical radiology tab. This is a graphic I took from the Royal College website, which just gives a very sort of brief overview of careers in radiology, some of which isn't relevant today. But I guess most of you on the call probably are somewhere over on the left-hand side at the moment. Your medical students. I did notice one or two names that I recognise from people who are a little bit further along in their training that snuck into this meeting. But if you're at this stage here as a medical student, and most of what you're going to hear us talking about is somewhere up at the special training and consultant level, there's obviously this bit in between that at some point you're going to need to have a think about. Now, I'm not going to talk through that in detail, but at the end, if there are any questions about this route through the foundation and junior doctor years into specialty training, we can always come back to that if they haven't been covered by the other speakers. Just one important thing to note is at the moment, the way recruitment into the specialty of clinical radiology is managed, there is an entrance exam called the MSRA, the Multi-Specialty Recruitment Assessment, which is actually an exam that is held for entrance into a number of different clinical specialties, and that exam really is sort of the gatekeeper into the specialty at the moment. If you get a good enough mark in the exam, you then get called to interview, and then if you successfully interview, you enter into the clinical radiology training pathway. And in clinical radiology training, there are 5 basic sort of years of training. There's a 6th year if you're interested in interventional neuroradiology, which we will hear about later. But I just wanted to mention that really for the first 3 years or so, you cover all aspects of general radiology. So it's not specific to neuro at all. You cover everything from the top of the head to the tip of the toes. And there are some fairly big exams along the way, the Royal College of Radiologists fellowship exams. The part 1 happens somewhere generally in the middle of the first year. And then there's part 2A and B that occur sort of around the 3 to 4 years in mark. And again, those exams are in all different areas of radiology. it's only really beyond this point where you really take a special interest in neuroradiology. So it's fairly late on. So I guess the reason I'm telling you this is just so that at the moment you may be very focused on neuroscience, but to become a neuroradiologist, there is going to invariably have a period of time where you have to not only do your junior doctor years, but also cover the breadth of clinical radiology to get into the specialist neuro training. Okay, so that I think just sets the scene, and our speakers are going to, as I say, cover aspects of training and practice in their own areas as we started. So just want to also mention, if you have any questions along the way, please feel free to post your questions in the chat. I'll try and keep an eye on the chat questions as we go along. Hopefully will be a little bit of time at the end of each talk to answer any questions that are specific to the talk that you just heard. And then there'll also be a Q&A session at the end, which I'm going to hang around for, and I hope a couple of the other panel members may still be around for as well. If you have any specific questions about interventional neuroradiology training, Dr. Stockley's not going to be able to stay till the end, so you might want to ask any questions as we go along in the chat, or perhaps we could take a few questions as we go into the coffee break happening. Okay, so hopefully that's set the scene, and without any further delay, I'm going to hand over to our first speaker, Dr. Tom Campion, who is going to talk to us about some of the general aspects of diagnostic neuroradiology that he does on a day-to-day basis. So over to you, Tom.
All right, good morning, everyone. So thank you very much for dialing in, and it's really good to see so many people who are interested in potentially going into neuroradiology. So I'm going to talk about what is essentially general diagnostic neuroradiology. So I am a bit of a jack of all trades, and you're going to hear from the masters of each specific one after me. But what I'd like to do in this session is basically very briefly talk about how I got here, because everyone takes a slightly different route, and I think you'll see a variety of different routes into neuroradiology over the next few speakers, and I think that's really important because not everyone knows what they want to do straight away. I'll talk briefly about what I do on a day-to-day and a week-to-week basis, and then we'll have a little morning in neuroradiology, and you can see some of the cases that we might see. So just to talk about my path in, I basically stayed on the conveyor belt, it has to be said. So I've done it, I think, almost as quickly as it's possible to do. And as I said, it's very important to realize that there are lots and lots of different ways of getting in, and that you absolutely do not have to do this if you want to try some other things along the way, but this is just how I happen to do it. So I spent 6 years at medical school. For those of you who are currently ranking your foundation program jobs, you can see that mine had very little to do with neurosciences, and I think obviously, I hope that you get the jobs that you want, but any experience is good experience. So don't worry too much if you don't get a neuro-related job immediately. Although, having said that, ITU was quite important for me in deciding that I didn't want to do neurology or neurosurgery, which were also candidates during medical school. So then I went into radiology specialty training, and I also did a master's over the course of my foundation program and at the beginning of my specialty training, which really sort of cemented that this was what I wanted to do, and helped me get involved in a bit of research when I was as part of my radiology specialty training. Then I went on to do a neuroradiology head and neck fellowship, and most of us would have gone through this path who are consultants now, but it's changing a bit and there aren't defined fellowships. So a lot of people will actually stay where they are, or there'll be kind of local training programs for neuroradiology. That meant that I did an extra year, so I finished at the end of ST6 and I did head and neck as well. And I also started doing an educational master's during the fellowship, which I'm carrying on now. And then a couple of years ago, I became a consultant. So I've not really practiced in a non-pandemic environment yet, but I hope to do that in the future. But I just wanted to show you that because I think lots of people have lots of different routes through. This is the route that I took. And I was pretty sure, I think, about what I wanted to do early on, but that's certainly not the case for a lot of my contemporaries who've tried lots of different things before they've ended up in what is obviously the best specialty. And the other thing is that I think particularly in radiology, obviously this is not the whole story. So between specialty training and my fellowship, I took a few months out because we had a kid and I wanted to spend some time with him. And then between fellowship and consultancy, I also took a couple of months out. And I think radiology and neuroradiology are things that are easier to work around the other things in your life than some other specialties. And it might not be something you're thinking about now, but whether it is children or whether you have other activities or hobbies or whatever else, I think it's really important to think about what you want to be doing as a consultant and how you want to be spending your time. And one of the things I've really appreciated about neuroradiology is I've been allowed to build up a job around the things that are important to me. And I think that's definitely worth taking into account. So this is what I do on a kind of week-to-week basis. So I work full time, but I've compressed that into 4 days, and I think that's becoming increasingly common. It won't be possible at every single hospital that you work at, but a lot of places are becoming more flexible. We also have the option to work from home a day a week as well. And you can see that I've sort of built up this job plan around the things that I find interesting and the things that I want to do. So I have a neuro-oncology day on a Monday, which is all about brain tumours and METs. So we have an MDT for radiotherapy planning. We have our neuro-oncology MDT with the surgeons and the oncologists and palliative care and the radiographers and a whole multidisciplinary team. And then after that, I go and sit with the oncologists and the neurosurgeons, and we essentially draw around tumours together. And it's quite a nice way of just spending some time with the clinicians and getting to know them, and also understanding what they do and how we can be helpful to them. And I spend the afternoon doing some acute reporting. On my Wednesday, sort of my head and neck day, I spend the morning either with the endocrinologists, doing pituitaries and parathyroids and thyroids. And then we have a head and neck oncology MDT where we talk about head and neck tumours. And in the afternoon, we have a skull-based MDT, which is halfway between neuro and head and neck. And we have a rapid diagnostic clinic, which is where the radiologist goes and sits in the ENT clinic, and we get patients that are sent round, we do an ultrasound of them, and we have a pathologist sitting next door. So we can take samples from neck clumps, take them through to the pathologist. The pathologist tells us that our sample is rubbish and we have to go back and do it again, or they give us a diagnosis on the spot. So it's really good feedback for us. It gives us a chance to be involved in patient care. And it's a very good service, I think, for the patients. On Thursday, we have the other MDT, so I have a neurosciences MDT and a neuroinflammatory MDT, which is diseases like multiple sclerosis. And then I have non-clinical stuff for the rest of that day. So I am supervising my educational clinical supervisees. I do some teaching, and I spend a lot of time doing BSNR work in the afternoon. But that's also a time for doing kind of research projects and audits and other things that you can't fit into a clinical day. And then on Friday, I have my ultrasound list where I do biopsies and FNAs, so sampling from neck clumps and seeing GP and other head and neck patients. I do some teaching, and I do acute reporting on Friday afternoon because that's what you do as a new consultant. It doesn't have to be, but and we have an on-call, which is 1 week in 8, where we take all the neuroradiology issues for the whole week, including overnight and weekends, but we have a registrar first on. So it's a busy weekend and you get the odd phone call overnight, but it is nothing like being a neurosurgeon, or, as I'm sure Dr. Stockley will tell you, an interventional neuroradiologist. But it's useful that they're able to contact us if there are any acute issues. And the other thing that I really love about neuroradiology is radiology in general, to be honest, is you really feel like you're in the center of the hospital and everyone is coming to you and you're advising everyone. I was sort of surprised when I became a consultant at how many different groups of doctors I was developing professional relationships with. And the more I do it, the more kind of rewarding it is. And it's really nice to know that you've got allies everywhere in the hospital, and that you build up these things and people will come to you for advice. And some of them are just not things you'd expect. We've got really good working relationships with the respiratory doctors because they keep asking me about supraclavicular lumps, which is not a group that I thought I'd be particularly close to when I became a neuroradiology consultant, for example. But there are obviously some groups that you're working very closely with on a day-to-day basis, but it's a really nice variety across the hospital. So now we're going to see a few of those people in the reporting room. So these are all obviously people who work in my hospital, and they've all poked their heads around the door on my day in acute reporting. So let's see what cases they've brought to us. And if you'd like to, you've all seen lots of cases of brain scans before. So if you've got any thoughts about any of the cases, please put your thoughts in the chat. We'll have to go through them fairly quickly, but if you think you've seen something before, it'd be great to know about it. So first up is Mr. Boyle. He's brought in a patient. He says, well, we've got this 20-year-old male who was found down after a fight. We know there were knives involved, but we can't find a stab wound. He's not really talking to us, and his brain scan looks a bit odd. Can you take a look? So let's take a look. This is a CT angiogram. So there's contrast, and the contrast is in the arterial phase to highlight the arteries. So the bright bits that you can see are arteries. And I'm just going to let this run through, but you'll see immediately that there's lots of this very, very dark stuff in the brain. And if we re-windowed this, you might be able to see more easily, but this is essentially gas. So they've got a whole load of gas in their head, but it's not entirely obvious where that's coming from. If we come down though, and we look in the pharynx, so junction of the nasopharynx and the oropharynx, you can see there's a little divot in the mucosa here. And if we go a little bit higher up, you can see there's a little irregularity in the anterior arch of, that's the C1 vertebra. So we think, maybe we've got a stab wound there. So the next step was to go on and do an MRI scan. And the important thing when we're thinking about penetrating injuries is to look along the trajectory of the wound and see what might have been hit on the way. So this is a T2 weighted MRI scan through the craniosacral junction. And this highlights, I think, quite nicely the path that this stab wound has taken. So he was stabbed in the mouth, and it's gone through the back of his pharynx. It's gone through the anterior arch of the C1 vertebra, and it's gone through the apical ligament and the atlanto-occipital membrane. So this has gone through the craniosacral junction ligaments, and it just missed the medulla by a matter of a few millimeters. So this could have had a very different outcome. But luckily, we were able to advise on the risk of CSF leak and infection, and he's actually done quite well. So next, the radiographer working in CT comes around, and she says, the stroke team want a post-contrast head for this scan, but I just saw another one just like it. What do you think of this? Usually if a radiographer comes and tells you that they think that there's something wrong with the scan, they are right. So it's useful to just agree with them. But we looked at this CT scan and we thought, well, I mean, to be honest, it does sort of look like there's a little bit of hyperdensity here. So possibly there's a mat and maybe there's some edema around it. But then the radiographer said, well, yeah, okay, but look at this one that I did about 20 minutes earlier. And she said, oh, okay, this also looks like there might be something here and a little bit of edema around it. It is a bit odd, and they were both on the same scanner. So the useful thing about a CT scan is it's acquired as a volume, so you can reconstruct it in any plane you want, and you can do obliques. But we just did a coronal reconstruction of this CT scan, and you can see actually that that hyperdensity extends all the way down across the brain. And it's very linear, and pathology is very rarely that respectful of straight lines. So a little bit odd, we go to the other one, we do a similar thing. And again, this one even more so, you can see that there's a straight line going all the way down across it. So this is an artifact. This is something called ring artifact, and it usually occurs when there's a problem with a detector. So if you recalibrate the detector or sometimes replace it, then you can remove this artifact. But it's very important to be aware of these things because obviously it can be mistaken for a lesion. So we need to learn a lot about how CT and how MRI work so that we can work with radiographers who obviously have a huge amount of professional expertise doing this day in, day out. And we can understand whether these are real or pseudo lesions. So next, Dr. Sloan comes in and he says, well, I've got this 35-year-old man with facial pain and swelling. The teeth look okay. There's something in the parotid, and we're worried that there might be a tumor. What do you think? So take a look at the CT scan. You can see there's some asymmetry in the parotid gland, and there is something there, and it looks a little bit dense. It's a bit funny for a tumor, but it doesn't have a good kind of peripheral enhancement that you'd expect for an infection, but it could be kind of inflammatory mass. We're not quite sure what it is. So the other thing we need to be able to do as radiologists is to think about, well, how can we take this forward? So we brought the patient round into ultrasound. And this is an ultrasound of the parotid gland, and you can see that there's this hypoechoic lesion here. And what's useful about this is you can see that there's some we call posterior acoustic enhancement, which means it's a bit brighter behind the lesion. And that tends to suggest that what we're seeing is fluid. So we've got a lesion filled with fluid in the parotid gland. They've got swelling. It was very painful. When we talked to the patient, he said, well, yeah, I've had some fevers as well. So we do what radiologists like to do, and we stuck a needle in it and we sucked out about 5 mils of pus. And subsequent to that, he felt much better. And that's the needle that you can see coming down into the lesion as we suck out the pus. So as a radiologist, it's useful to be aware of what your potential tools are and how to use them best to make patients feel better. So next, the neurosurgeon comes in and says, well, we did this decompressive craniectomy for someone who had a left middle cerebral artery stroke. We put a lumbar drain in, but he's dropped his GCS. Do we need to go back in? And you bring up the scan and it looks a bit scary. So you think, okay, well, let's just try and work out what's going on. So the other thing that we do a lot as radiologists is go back and look at the previous imaging, because the story is usually there in the previous imaging. So let's go back to the beginning of this one. This is what the original scan looked like. And at this stage, you can just about make out that we've lost some of the basal ganglia on this side. We've lost the insular cortex. These are signs that this person is having a left middle cerebral artery territory infarct. Unfortunately, it went on to have very significant hemorrhagic transformation and extension of infarct. You can see the anterior cerebral artery territory is involved, and so resulted in having a decompressive craniectomy. Now, on the scan after that, you can see that the ventricles were blowing up, and there was actually herniation out through the craniectomy defect. And they put a lumbar drain in to sort of reduce the pressure from the inside. And now this flap has sort of sunken down inwards, and you've got midline shift, but it's going the wrong way. It's going towards the right side, whereas you'd sort of still expect it all to be pushing out through here. And there's some uncal herniation, which you can't quite see, and subfalcine herniation here. So there's clearly a problem with pressure. So do they need to go back in? Well, no, because what's actually happened is that they have taken so much CSF off through the lumbar drain that they've decreased the intracranial pressure, so it's lower than the atmospheric pressure outside. So they're basically sucking the brain inwards. So if they adjust the rate at which the lumbar drain is removing CSF, then actually they'll fix this without having to do any more surgery. And that's what happened, and the appearances improved. So as radiologists, really important to go back through the previous imaging, but also to have an understanding of what the clinical issues are that might crop up in any particular given scenario. So next, you get the medics popping their head around the door. They've got a 25-year-old with left-sided weakness and some strange sensory symptoms, but I think he's a bit young for a stroke. So this is the CT scan, which I've windowed quite heavily. And on this, I hope you can see that there are lots of little dots of hypodensity on the CT scan, which we might expect to see in someone who's old, who's got lots of vascular risk factors, but in a young man is very unusual. So he got a fairly acute MRI scan. And on the MRI scan, you can see these multiple lesions in the white matter, which are involving the periventricular white matter and extending right down to the ventricular surface, and also going up and touching the cortex. So these are very kind of characteristic imaging features for demyelination. And the most common demyelinating disorder is multiple sclerosis. And we also had a post-contrast scan, which you can see here. And there is one lesion here, which is enhancing, and one lesion, which is not enhancing. So once they've done a whole bank of other tests to make sure that there's nothing else going on, and we've done some follow-up and had a bit more of a chat about the history in our neuroinflammatory meeting, we were able to use this imaging to come to a diagnosis of multiple sclerosis. And if we diagnose him early, we can get him on treatment early, which will improve his outcomes. And finally, we have our doctor from the emergency department who pops by, and she says, we've got a really strange one here. This poor man, he's in his 90s. He has a bureau which has a ring holder, which is essentially a welded metal spike on his desk. And he fell over and he's got lodged on it. So the fire department has cut the spike off the desk, but it's still lodged, and we're going to need a bit of help. So you do the CT and the scanogram and you think, this is not in a very good location. It's going right through his orbit. So we're going to do a CT scan, and again, we've done a CTA, and you can see from the CTA, if we come down to the level of the orbit, it's actually scraped on the underside of his globe. So it's not gone through the globe, it's gone under the globe, through the orbit, but it does seem to be lodged right next to the internal carotid artery, which you can see just here. So it might be a bit problematic taking it out. So at this point, we went over to our helpful interventional neuroradiologists, and they said, well, look, what we can do is we can just snake a little balloon up through the internal carotid artery. And if it does turn out that it's lodged up against the internal carotid artery and it makes a hole when we pull it out, we'll just inflate the balloon. So everyone crowded round into the angio suite to watch our interventionalists do this. They put a little bit of contrast up through the internal carotid artery to see where it was, and then out it came. And luckily, he was absolutely fine. So, as I'm sure again that Dr. Stockley will tell you, our hero moments are often reserved for our interventional neuroradiologists. So I hope that I've shown you that general neuroradiology can be very varied. I find it really interesting, and it really covers this whole breadth of neuroscience that you learn at medical school, and you really apply a great deal of it when you're thinking about neuroradiology, and it's constantly challenging. There's the opportunity to do procedures even if you don't feel able to go the full interventional route. You get to use cutting edge technology, and you just get to meet a huge variety of people, both patients and doctors from across the hospital. And I think there's a real opportunity to take all of these different kind of subspecialties and really make the job your own. So when you see all the different subspecialty talks today, you'll get a feeling for things that you like and things you don't like. You don't have to choose one or the other. You can really find a mix of them that suits you and works around your life. So I'm happy to take any questions now, or happy to move straight on. I'm also happy to take any emails or be approached on Twitter, but I'll come back for the Q&A at the end if you've got any questions then. Thank you very much.
Brilliant. Thank you ever so much, Tom. That was a fantastic first talk, really set the scene, and some really, really nice cases that I'm sure all of the neuroradiologists on the call recognise from their own on-call activities. So thank you. I can't see any questions in the chat at the moment. If anyone wants to pop up a hand and ask a quick question, Tom, you can do, or save it for the Q&A at the end. Okay, I can't see any hands up, so we'll go straight on. So our next speaker is Dr. Leilani Carlton-Jones, who is going to talk to us all about spinal neuroradiology. So over to you, Lau.
Sorry, just unmuting myself. So good morning, everyone, and thanks again to Rob and Sam for allowing me to speak in a very croaky voice this morning. I'm sort of recovering from COVID. Apologies for that. And I'm going to be talking about spinal neuroradiology. I have a very similar role to Tom, and I think my job is really varied and diverse, and I'm really going to hope that I'm going to convince some of you to maybe think about neuroradiology as a career, as the rest of my co-speakers are hopefully going to do as well. Okay, so I'm a consultant neuroradiologist at Guy's and Tommy's and at King's and at the Evelina. I work at multiple sites, and I'm going to talk to you a bit about my path into neuroradiology, what a typical day involves for me, and I'm going to show you some diagnostic cases and some spinal intervention cases as well. So first, a little bit about my path. Well, this pretty much summarizes it. It was a bit long and winding, essentially, with a few detours. But I started off from probably about age 4 thinking I want to be a neurosurgeon, and that was heavily influenced by the fact that my father was a neurosurgeon and my mum was a neurosurgical nurse. So you could say that I had kind of had brains and spines around me from the beginning. And I thought, I'm going to do neurosurgery. And that was the path that I took. And I loved reading about it. And I went to university thinking, I'm going to do neurosurgery. So I went to Cambridge, did my undergraduate there, and then at the time we were able to go to London and other places to complete clinical training. So I completed that at Imperial, and then I undertook a range of surgical and medical house jobs and SHO jobs, as most people did in that time, which included neurosurgery. And I still loved it, and I loved the operating. But one thing that I noticed that I really loved was the diagnostic imaging and the challenging and the role that neuroradiologists played. Despite that, I still wanted to do neurosurgery. So I actually got a neurosurgery run-through post and spent a couple of years doing neurosurgery, neurology, neuro-ICU as part of that. And during that, it was that I noticed that I spent a lot of time with neuroradiologists who were generally pretty happy people. They seemed to love their job, and there was a mixture of providing a lot of clinical input to their neurosurgery and neurology colleagues, a mixture of hands-on work, and really importantly for me, no ward rounds and no clinics. So I thought, well, maybe I should think about this as a career, especially because they look like such a happy, nice bunch who also seem to have great personal lives as well. And it seemed to me that neuroradiology was a pretty rapidly advancing specialty. And even in the time that I spent, it has changed significantly, and I wanted to be part of that. So I gave up my neurosurgery training number and went into radiology. And I started my general radiology training in 2010 at Imperial. And at that time, you had to do general radiology first and then do a fellowship. So I did the Pan-London Neuroradiology Fellowship, which is where you rotate around the different centres in London for 2 years. And then I was appointed as a consultant at Guy's and Tommy's in 2018 and at King's. And I've just put a couple of the other roles there because, like Tom said, we have incredibly diverse careers as consultants. I do a lot of work with the medical school, KCL, have some Royal College of Radiologists role, and work with BSNR education. And it just makes the day job incredibly interesting because we're doing a variety of things. So let me take you through what a typical day might consist of. Now, the spinal aspect of neuroradiology, which is what I've been asked to concentrate on here, encompasses the full range of skills of a neuroradiologist. And the real workhorse of that is diagnostic reporting, but it's a pretty varied working day for me. I mean, I can be doing diagnostic reporting, leading MDT meetings, performing diagnostic and therapeutic interventions. And I'm going to show you some examples of some of these cases. So firstly, the bread and butter of neuroradiology is diagnostic reporting. And here's where we add the most value. And really close interactions with our clinical colleagues are really essential for that. And knowing what our clinicians want to know helps us to frame clinically relevant reports that aid in patient management. So more than just a description of findings in your reports. So just to take you through some of the spinal imaging methods. So let's have a look at some of the main imaging methods that are encountered in imaging the spine. So here's just, are you guys seeing my, sorry, Rob, can you just check, are you seeing my screen okay? Because I'm not sure if it's sharing my desktop now. It's looking like it's stopped sharing.
Yeah, I can see.
Yeah, okay, so okay, all right. So just to take you through a couple of the imaging modalities. So we've got, there are varied, and spinal Radiology employs a range of them, and they include radiographs, CT, myelography, which is where we inject contrast into the spine to help us get a bit more information depending on the clinical indication, and MRI. And of these, CT and MRI are the most commonly used modalities. And I'm going to show you a couple of examples of how these can be used. So just to give you an example of a trauma case. Now, one of the most common indications for imaging the spine is trauma. And CT provides really crucial information about bony integrity and alignment. What you can see here is that there's a fracture through the vertebral column at the T9, T10 level, through the body of T10. And CT provides that really crucial information about bony integrity. But with injuries like this, our neurosurgeons want to know about the soft tissues and the neural structures. So MRI is really essential. And we have different sequences in the spine that give us different and additive information about pathology. And you may have heard of some of these sequences. I'm sure you're all very, invested as students. We've got T2 weighted imaging, T1 weighted imaging, STIR imaging, SIR sequencing here. So we've got different sequences that give us different imaging information. So in addition to the fracture that we've seen here, we can see that the MRI has given us additional information that there's a severe injury to the intervertebral disc at this level, and that there's also injury to the posterior elements, the ligaments, and most importantly here, that there's a transection of the spinal cord. So here's the spinal cord here, and you can see that there's been a disruption, a complete injury to the spinal cord at this level. And then the axial imaging here shows us that injury to the spinal cord. Now, another case that I wanted to show was that discussion between our clinicians, our neurosurgical colleagues in particular, and us is really important and helps to make the diagnosis in patients. And what we say can often impact how the patient is treated. So this is an example of where imaging interpretation was revised in light of new information. This was a case from my training, but I've kept it because I think it highlights a really important point about keeping yourself up to date with the literature and sharing that information with your colleagues. So here we can see an image of the spine. The spinal cord looks normal around this segment, but here you can see that the spinal cord looks expanded. It's of abnormal signal. There's a little cystic area amongst that as well. We sometimes give contrast to help us highlight pathology, particularly if we suspect there might be a tumor there. And this is what the neurosurgeons had suspected in this case. There was no enhancement here. So the neurosurgeons felt, well, this is probably going to be a low-grade tumor. Somebody else who'd reported this said, yeah, I think this is a low-grade tumor. The patient actually had progressive weakness, but it had started to stabilize. So this got put into a, let's just follow this up as a low-grade tumor follow-up. And then I reminded them of this article that had just come out. This was a case that had come out in my training. This article came back out in 2013. And this is where this distinct entity had been described of a dorsothoracic arachnoid web, where they had this sharp, abrupt change in caliber of the cord. And it looks a bit like a scalpel. It was called the scalpel sign. And it's caused by an arachnoid web, which is sort of thin membrane, compressing the spinal cord at that level. And before the next follow-up MRI was done, this article had been published. When we look back at this case, here you can clearly see an example of a classic scalpel sign. So instead of being condemned to an imaging follow-up, the patient went for surgery and had their arachnoid web resected. And post-operatively, you can see the spinal cord looks normal again. So that's just to show that your imaging can make a difference in the patient's imaging report can make a difference in the patient's management, and to also keep yourself up to date with the changes in the literature and everything that's being published. So one of the best things I love about spinal neuroradiology is that it offers the opportunity to get up out of your chair, see patients, and perform image-guided procedures. So first up, I'm going to talk about diagnostic interventions to yield a diagnosis in those cases where imaging alone isn't sufficient. And then I'll talk about some therapeutic interventions. So this was a patient, a 40-year-old female who had back pain and leg weakness and urinary incontinence. And what you may be able to tell from this is that, I'll show you some stills of this in a second, is that here is the lower lumbar canal and the sacral canal here. And you can see that there's just something abnormal going on in the sacral canal and around it. And what we can see here is that there's an infiltrating mass in the sacral canal vertebral bodies, and it's extending through some of the sacral foramina where the nerves transit through into the presacral space here. And it's a sort of grayish intermediate intensity on T2, and that implies that it's going to be a cellular abnormality. When we give contrast, it has a sort of heterogeneous enhancement pattern, a bit irregular, and it just looks like an aggressive looking process. So we could say we think this is going to be a tumor, but it's non-specific, and we need to get a tissue biopsy in order to enable targeted treatment. So this is an axial of the MRI study. You can see the presacral mass here. So I've chosen to do a posterior approach. Inserted a 16 gauge needle under CT guidance through one of the posterior sacral foramina. And then you insert a smaller needle through that needle and deploy it into the mass to get you a tissue sample. And this came back to be a Ewing sarcoma. So then you're able to target treatment appropriately for this patient, knowing exactly what the biopsy is. And it can be done very minimally invasively and exactly targeted to where the mass is. But we can also perform therapeutic interventions, and performing image-guided spinal procedures also offers the chance to give patients relief or even cure of symptoms. And one of the most common that I perform as a neuroradiologist is an image-guided nerve root injection. So this is a patient who'd had previous surgery. So they'd had an anterior cervical discectomy and a fusion at C5, C6, but they've got new pain in their left arm and they don't want to have further surgery. So we've done another MRI scan to show we can see the evidence of the previous surgery here. And this is what it should look like normally on the axial imaging. You can see the spinal cord here, and you should have nice wide neural foramina where the nerves exit through. And what's happened at this C4, C5 level is that we've got a new little disc and a new little osteophyte that is now compressing the left C5 nerve root. So we can do a really focal guided C5 nerve root injection. Here you can see my needles placed right at the exit of the foramen. I inject contrast to make sure that we're not in an intravascular location. It's really important to do these under imaging guidance because you can see that here is the vertebral artery. So you want to make sure you're nowhere near that. And we inject contrast to make sure we're in an extravascular location and that we're getting a nice flow of contrast around the nerve and in an epidural location. The patient had complete relief of their symptoms. Here's another example. This is in real time. You can see the needle tracking into the C8 nerve root. And this series of images shows that needle approach to the foramen, test injection of contrast. And again, the approach to C8 can be really tricky because it's quite low down in the neck. So CT really helps here. And we use that needle to the CT to show the needle approach to the foramen, give a test injection of contrast, and then give the patient steroid and local anesthetic to give them. And patients can experience really substantial and long-lasting relief from these injections. And they're often really, really grateful. I had a patient, I thought I'd just include this in here. I had one patient who was so grateful that they, in fact, gave me their debenture seats to their box at Wimbledon that year. Now, unfortunately, we're not allowed to keep gifts like this, so I gave it to the GSTT patient charity. But it just shows how grateful patients can be when you fix these problems for them. Now, one of the last things I wanted to finish up on was to talk about my favorite topic, which I'm sure most of my colleagues on this are frankly sick to death of me going on about. But I wanted to talk about this because A, it's my specialist interest, but it's also a condition in which the neuroradiologist often makes the diagnosis, does the initial treatment, does the invasive specialist tests, finds the cause, and then definitively treats the patient. But we also do this with the support from our neurosurgical colleagues. Now, essentially, spinal CSF leaks are leakage of CSF in the spine, and that leads to a low intracranial pressure, and that can present to neurosurgeons. So if you don't take anything else away from this, remember that it can present to you with bilateral spontaneous subdural collections, and they can be spontaneous subdural hemorrhages. There are a range of other imaging findings as well that you can get and that are often associated, so we look for them, and that's what I've just showed you with this little mnemonic here, seeps, because of the CSF seeping. You get subdural fluid collections, dural enhancement and thickening, engorged venous sinuses. The pituitary gland can become enlarged, so it can often mimic a pituitary tumor, and you get sagging of the brain, all due to the low CSF pressure. But the main one I want you guys to remember as neurosurgeons is to think about it in the patients who have bilateral subdural hemorrhages, because it's often missed. And the thing is with these patients is you shouldn't drill burr holes for them because it will make it worse. You need to treat their spinal CSF leak. Now, spinal CSF leaks can result from a number of causes. And again, there's neurosurgical involvement in many of these cases, so important for neurosurgeons to know about. And they can result from little tears in the spine that are caused by little discs that cut the dura and allow escapage of CSF, either at the front part of the spinal cord or at the side near a nerve root, or it can be due to an abnormal connection between the CSF and a little abnormal vein, what we call a CSF venous fistula. Now, whatever the cause, the treatment for this is, in the first instance, to do a large volume epidural blood patch. Now, most of the evidence coming out is that you should do really large volume of patient's blood. And this is where you take the patient's blood and inject it into the epidural space. And we like to do this under CT guidance because we're injecting a large volume and because we're doing it in the thoracic spine near the cord and also in the lumbar spine. So I do these under imaging guidance. Here we have, you can see that I've inserted the needle into the epidural space. I inject a bit of contrast to make sure that we're in an epidural position. And then we take the patient's blood and inject it into that space. It sounds quite medieval, but it works and it cures the majority of these patients. In a small minority of these patients, we might need to go on and find actually where they're leaking from. And that involves us injecting a little bit of contrast into the patient's CSF space to see where they're leaking from. That's called myelography. And there are different myelography techniques depending on where we suspect the leak is coming from. So here's one of my radiographers. We just showing the positioning. We lie them on their tummy if we think that they've got a dural tear, and then we scan them up and down. Now you can see that we do several runs of the spine, and this is the contrast column. It's going further up the spine as we go up and down with the scanner. And this is basically a dynamic form of CT imaging after we've injected contrast to look for a source of leak. So here's an example of one where we haven't given contrast yet. We've done a scan of the spine. Can you notice that there's a little sharp little bit of bone here? We give the contrast, and can you see how now there's a split in the contrast column right at the point where that little bony spicule is? And that's because that's the point at where the patient is leaking. We can also show those leaks on digital subtraction myelography. So Hannah's going to talk a bit more about, I'm sure, her intervention cases in the angio suite, but we sometimes use the angio suite to do these cases because they give us a really good spatial resolution and allow us to look at leaks in real time. So remember this one I showed you where the bony spicule is cutting into the dura and allowing CSF to escape outside of the spinal cord and its coverings. Well, here we go. Here's an example of a case. The bone has been subtracted away. That's why we do it on this table. And here you can see that if I take you right back to the beginning of this case, the contrast is running up the spine. I've injected contrast. Here, this motion is from the heartbeat, but here you can see the point at which the contrast is now coming out of that sac and layering in the epidural space. Here's an example of one we've done under CT. And this is a decubitus myelogram, so it's done with the patient lying on their side. So here's the spinal cord, here's some contrast within the CSF. And what you can see in this case is that there's contrast more densely layering on this hand side of the patient because they're lying on their left side. And here you see a very abnormal little network of veins on the left. And then it's all jumping into this vein, which is traversing across the vertebral body and that is exiting around the other side. So this is an example of one of those CSF venous fistulas that I talked about, where there's an abnormal connection between the CSF and a vein. And the great thing about those is that we can treat them, again, minimally invasively and cure them. So here's an example for that patient where I've done a CT-guided injection. I've placed my needle right at the point of the CSF venous fistula. Check the position with giving a bit of contrast, make sure your epidural space, and then we inject something called fibrin glue, which is basically like super glue into the vein to seal it, and the patient was completely cured of her intracranial low pressure. So this is just a photograph to just show you really only some of the team that I work with, but just these are some of the neurosurgeons I work with, neurologists, my radiographers and nurses, just to show that the majority of the work that we do is completely team-based, and we form great relationships with these patients and people, both inside and outside of work. And really it is team-based care to deliver the services that we provide. So hopefully I've shown you that spinal radiology encompasses diverse pathology, that neuroradiologists have both a diagnostic and a therapeutic role, and we have both grateful patients and clinicians in the roles that we provide. I just want to finish with a little plug for the BSNR educational program, which Tom and I and others here are involved with, but that if you want to look at any of the lectures, please go to the BSNR website. We have lots of pre-recorded lectures right here where you can see a lot of our webinar recordings, and also sign up to the program to view any recordings going forward.
Okay, that was brilliant. Thanks ever so much for that talk, Lau. Fascinating cases. And I think you've actually made a really important point in your talk, which is one of the things I really like about neuroradiology is the fact that it's an evolving specialty and new conditions seem to be popping up all the time. You know, neuroradiology, as I learned it when I was a fellow some years ago, has changed so much, and I find that aspect endlessly fascinating. So there is one question that's popped into the chat. I don't know if you've seen it, Lau.
No, I can you read it out for me. I can't. Sorry, I'm just trying to struggling to find my chat here.
Okay, it's
how do you get access for the contrast? Oh yeah, sorry if I didn't make that clear. So that is literally you basically you do a CT guided LP. And the reason we have to do it under CT, we don't, the way that Rob's just made a point here is that, you know, 5 years ago, and even now in some centers, we didn't know that CSF venous fistulas, for example, existed just because we weren't doing the right imaging method. And we were often doing these lumbar punctures in fluoro, taking the patient around to CT. And by that point, the contrast concentration has gone down. So you're not going to find these little abnormalities that exist. So we do a CT guided injection, place the needle under CT guidance, and then inject the contrast that way. And we inject the contrast slightly differently depending on the leak type that we think it is, because we have to position the patient differently to what we think it is.
Okay, and there's also a question from Sehai, who asked, a neurosurgery SHO, I really like being in neurosurgery, post-op satisfaction, managing post-op complications as well. I wondered, do you still have the same radiology I consider it a part?
Okay, so the thing that I really love about performing interventional, I'm also going to answer Connor's question. In a typical week, how many days do you spend doing therapeutic spinal intervention? So I spend 2 days doing it. Although I'm currently being asked every day to do it now because I'm actually the only one who's doing it at my institution. So I'm trying to train someone else at the moment. So I love doing the cases, and the reason I love doing these cases is because they're really grateful patients, really super grateful. These, especially the spinal CSF leak patients, have often suffered for a while. This condition is far more common than we think it is. It's missed in a lot of places. I'm sure my neuroradiology colleagues will agree with this. And then they often come to us having suffered for quite some time. But also patients who we do nerve root injections in, they're often very grateful patients. They're generally pretty low risk procedures as well. I personally, when I was a neurosurgeon, I didn't really love the patients who had really high perioperative mortality and morbidity. I'm sure Hannah's going to talk about that. She's got really, you know, great strength. I couldn't do what Hannah does, because, you know, they're much sicker patients. I prefer relatively well patients, let's say. So I didn't love dealing with that side of things, but I loved being interventional and doing practical aspects. But I like to have it in a more let's say measured environment, you know, controlled environment. And I haven't really had any significant complications yet. But the key thing here is that I work as part of a team, and I work as part of a really supportive team. And I really mean that. So if I'm ever worried about a patient, I don't ever hesitate to get on the phone to whoever the neurosurgeon or neurologist is, because that is part of the team. We all work together. And, you know, we have had some patients, you know, one of the complications of definitively treating patients with low pressure is that their pressure can go the other way. They can go into rebound hypertension. We have had a patient who's had a really severe rebound hypertension, and it's really when then all the team comes together and helps manage that. But that's why I rely on my clinical colleagues to help that. So yeah, I wanted to stay off the wards, doing procedures, but without necessarily doing the clinics and ward rounds and things like that.
Wonderful. Thank you ever so much again, Lau.
No worries.
Okay. So we're going to move on to our next speaker now, Dr. Sam Mills. I realised that at the very beginning of this talk, I forgot to introduce both myself and Sam as being, so we're both in the BSNR academic subcommittee. I'm the chair, and Sam is the deputy chair at the moment. And it was really through Sam that this webinar ended up being organised. So I apologise, Sam, for not having said that at the beginning. But anyway, I'd now very much like to hand over to Sam for her talk on neuro-oncology.
Thanks very much, Rob. So yeah, I'm going to talk a little bit about neuro-oncology, which is my specialty interest really with regard to neuroradiology. A little bit of background about me. I'm in an aeroplane. I spent a lot of time with aeroplanes before I went to medical school. I still love aeroplanes. So I started a long time ago. I integrated in a neuroscience degree in between my 3rd and 4th year at medical school. And that was probably where I decided I loved neurosciences more than anything else. And I'll point out at this point, I was on a career pathway to be a neurologist, not a neuroradiologist. I graduated in 1999 and then went to my house jobs, just general house jobs in surgery and medicine. But I did an SHO job in neurology at the centre I work in now, because that's what I really wanted to do at that point in time. And this was the career defining job for me, really, because I went there and didn't like neurology at all as a job. But I did see what the neuroradiologists were doing, and they really loved their jobs. They were the happiest people in the hospital, and everybody interacted with them. They spoke to the neurosurgeons, they spoke to neurorehab, they dealt with the radiographers, the specialist nurses, and they were certainly the centre of knowledge for imaging. I carried on with some medical rotations, and in 2002 I started my radiology training, and at that time all I wanted to do was neuroradiology. So I put up with a few years of general radiology, looking at chest x-rays, doing some barium enemas. I took some time out in the middle of my radiology training and did a PhD, again, focusing on neuroradiology and looking at neuro-oncology imaging. So looking at advanced MR techniques for use in neuro-oncology patients. It took 4 years, but that's because it took 3.5 years because I had a baby in the middle of that. So I had 6 months maternity leave. I came back and completed my neuroradiology training, which was reduced because some of my PhD counted for my neuroradiology. And then took a consultant post in January in 2011, initially at Salford, and then I moved over to the Walton Centre in 2014, where I've been ever since. So this is my typical working week. I do a lot of general diagnostic neuroradiology as well, which you've heard from Tom about. So I usually do duty hot reporting all day on a Monday, just because it's easier that way. I like to get it over and done with in one go, and we can report everything. A bit of reporting on a Tuesday. Wednesday might be preparation for the neuro-oncology MDT. Sometimes I'll try and squeeze in a bit of teaching in there as well. Thursday, again, a bit more reporting and checking the registrar's film, and that's when the MDT actually happens. And I try and do my research on a Friday. There's a picture of a cat here because I have a couple of days a week where I report purely from home, usually on a Tuesday and a Thursday. And even the IMRI scans, the intraoperative MR cases, we can do from home, and it works quite well. My on-call is a 1 in 8. I don't usually have a radiology registrar on with me because we have no A&E department at the Walton Centre, so our on-call is rather different to everyone else's, but it's fine. So I've said we already do a bit of general diagnostic neuroradiology, but I do a lot of brain tumour imaging and a lot of advanced imaging with that, and a lot of intraoperative MR imaging with that. And then we've got the MDTs as well, and there is ample research opportunity with regard to neuro-oncology. So I'm going to take you through a single patient to really show you the role of the neuro-oncology radiologist at every time point for neuro-oncology cases. So this is a 30-year-old male. It had a single seizure, just one fit, and was referred to the neurologist because the neurologist thought there was a low likelihood with just one episode of seizure. He had a CT scan. This was a CT scan that was first on the list. I think it was done at about 8:30 in the morning. And I was walking into the department and they said, there's something on the scan. So this is our CT scan. We've not given contrast, but we can see that there's some areas of hyperattenuation on the CT, and you can measure the Hounsfield unit of that, and it shows that it's probably a little bit of calcification within that, as well as some areas of hyperattenuation, which is due to the mass. So because our hospital is slightly different to other hospitals, and we have no A&E, we've only got one CT scanner or 1.5 CT scanners, and we have lots of MR scanners. We took him straight round to the MR department and put him on the MR scanner. So now we can see that we've got a right frontal parenchymal lesion, which is involving the middle and superior frontal gyrus, and it's got some extension to the genu, which tells me that it is likely a primary glioma of some sort. We can do some more advanced imaging, and we can do quantification, quantifiable imaging, which is the use of diffusion weighted imaging. And we can get this measure called an ADC, which is the apparent diffusion coefficient. This is a pretty good measure with regard to MR imaging in radiology, because you can take the same patient and put them on any scanner, and you should get thereabouts the same ADC value for the thing you're measuring. Why it's useful in tumours is the lower the ADC value, the higher the likelihood of higher grade malignancy it's going to be. And it's to do with the free movement of water molecules. So as the cells are more densely packed, there's less water diffusion, so your ADC goes down. We can give contrast as well. When you get breakdown of the blood-brain barrier, you can get contrast leakage into the brain parenchyma, into the tumour, and it's an indication again that this is probably a higher grade malignancy. So from the imaging that we've just done, just conventional CT and MR imaging, we can tell that this patient's got a right frontal parenchymal tumour. It's got some calcification within it, which makes it suspicious of a histological subtype called an oligodendroglioma. But there are some features as well that are pointing it towards a little bit of malignant dedifferentiation. So, and that's the pattern of enhancement within it, and the fact that the ADC value is low. So even without sticking any needles in this patient, we're already suggesting the patient's got a higher grade tumour, and we've got some idea of the histological subtype. So the patient's then referred to the neurosurgeons, and this is their clinical request. They want some more information, and this is where the neuro-oncology radiologist can help them. So the patient is actually left-handed. Okay, this is quite important because the neurosurgeon wants to know where Broca's area is. So Broca's area is the language area, the language motor area, and it's typically dominant in the left hemisphere and most right-handed patients, but in left-handed patients it can be a bit more complicated. So is it high or low grade? We're already a bit suspicious that it might be higher grade, and our neurosurgeons are very polite. Can we please do a volume FLAIR as well? They're going to operate in 4 weeks' time, so it'd be good if we could do it very soon. They're very polite. So this is an example of where Broca's area is, and we can see with our tumour that, in fact, although it's in the right hemisphere, it's quite close to where we think Broca's area might be. So we can do an advanced imaging technique called functional MRI. And what this does is we put the patient in the scanner and we give them a load of tasks to do. It's easiest if I explain this with regard to motor tasks. We might ask the patient to lie in the scanner and touch each finger and thumb individually, and then have a period of rest, and then repeat the activity. And we keep repeating this over and over again to try and identify areas of brain activation. With regard to looking for Broca's area, we're going to ask them to generate some language and some speech. We ask them to do word generation and then pause for a bit and then repeat the task. And we can see which areas of the brain activate when they're doing these tasks. So for our left-handed patient, we found that there is bilateral language representation. It's a bit more dominant in the left hemisphere, but the Broca's area of activation on the right lies along the infralateral margin of the tumour. So this is going to help the surgeon decide on their approach. And as we know with neurosurgeons, everything is about the approach and what they're going to do. We can also do some more advanced imaging, and this is physiological imaging, and we talk about perfusion imaging here. We can do this with 2 techniques. One of them is dynamic susceptibility contrast imaging, and the other one is a non-contrast technique called ASL. We've got spectroscopy as well, which can look at the metabolites within the tumour, and a step along from diffusion weighted imaging that looks at the free water movement, we can apply some tracks to that and look at the tracks and the tractography. So here we can see we've got a colour map of the, this is the DSC perfusion imaging. We can see that the tumour here is increased cerebral blood volume in the tumour itself, whilst it's lower blood volume in the contralateral normal appearing white matter. And if we look at the curves, we can see that the curve is deeper and the red curve in the tumour than it is in the normal appearing white matter on the contralateral side, which is green. And that tells us that the blood volume is higher in this tumour. If we do the same thing with the ASL, which is a non-contrast technique, we can see that the blood flow is markedly elevated. So these are pointers that this is a vascular tumour, that there is angiogenesis going on, and that this is going to be a tumour of higher grade. It's important for the surgeons if we can identify if there's little areas of higher grade, because that's the bit we want the surgeon to target in order to get an accurate histological diagnosis. Spectroscopy is another technique we have in our bag. Now, it doesn't give us a pretty picture of the brain like you would expect. It is a graph that we get, and we do proton spectroscopy. We're looking at the resonance frequency of the metabolites. We measure it in parts per million. The graph reads from right to left. The other things, we need to have the voxel away from the fat, so it's not very good if the lesion's near the scalp or the skull, and we suppress the water signal. So this is it in its simplest form. We look at the choline, we look at the creatine, and we look at the NAA. So the NAA is a neuronal marker. So in tumours, this tends to fall as the neurons are destroyed. The choline is a cell membrane marker, and this can become increased in tumours because the cell membrane get disrupted, and creatine can be stable. Sometimes it can go a bit low because it's energy metabolism. We talk about the upward slope of this graph being Hunter's angle, and then this is our patient itself. So we've got our normal appearing white matter, and on that we've got a nice normal upward slope. So choline goes to NAA, and then the contralateral side, we can see we've got a fall in NAA, the choline goes up, and the creatine's a bit low or stable. But we've also got these other two metrics that come in, lactate and lipid, and this indicates that there's probably some necrosis going on, and that this is again a feature of higher grade tumour. So I talked a little bit before about diffusion weighted imaging and looking at free water molecule movement, and we can take this further and look at tractography and look at the directionality of movement water, and we can measure not just the ADC but also the fractional anisotropy, and these are measures that will again correlate to whether the tumour is higher or low grade, because as the tracts are destroyed we lose some of that fractional, that directionality of the water movement. And you also, for the surgeons, we can use that data to actually plan and plot the tracks. So it can help show whether the tumour is destroying the snaps or just merely displacing them. And if you're displaced to one side, the surgeon might want to alter their approach to avoid destroying those tracks in their surgical planning. And this is the same patient here. We've overlaid the tracks as we've plotted on there, and you can see that a lot of the tracks are pushed posteriorly and displaced laterally and posteriorly. So you're probably not going to want to take a posterior approach for this tumour. So going back to this patient, we've shown that we've got bilateral language dominance, which has got close proximity to Broca's area. We've got advanced imaging sequences as well that support what we've suggested on the conventional imaging, which are indicating that there are probably features of malignant transformation and high-grade features. The conventional imaging with the CT shows us some calcification in the tumour, and we're indicating it's probably going to be an oligodendroglioma. So the surgeon has now said we're going to plan for an awake craniotomy, so operate on the patient while they're awake, so they can have neurophysiology as well, and the psychologists in there testing their language. But we're going to do some intraoperative guidance as well, so we can check how we're doing during the operation and make sure and see where we need to go back in again. So this is our intraoperative MRI suite. We can see that the scanner is quite a large room. We've got access to the theatres here. There is another door at the back which also potentially opens to a theatre, but that's not in use at the moment. We don't have it actually within the operating theatre, so when it's not in use for an intraoperative case, we can use it for conventional routine imaging. And this is the plan. We've got the control room, we've got the IMRI scanner here itself, and there's the operating theatre, but there is access to other parts of the neurosurgical department, but we can use it as a standalone scanner as well. And that door is not open yet to the other theatre, but could potentially be opened in the future. There is a ream of safety questionnaires that we have to do in order, so the patient has their surgery, we get a half-hour warning, the scanner's cleaned, they have to go through a whole series of safety checks to make sure that there are no ferromagnetic materials left in the patient, there's no instruments around, and there is actually on this list a safety check, a tick box to say we've completed all the safety tick boxes as well. So it takes quite a while to prepare all this, but we have to be very thorough and very safe. The surgeons and the radiographers that are dealing with the IMRI cases have special set of scrubs with no pockets in them, so no one can hide any ferromagnetic pieces of equipment or pens or scissors in their pockets to make it safe. We started back in about 2017. By 2019, we'd done our first 100 cases. We generally do probably 1 to 2 a week. Sometimes we've had obviously a lull with COVID. We do a range of adult parenchymal cases as well as pituitary cases, so we're a bit unusual in that we do pituitary cases, but we have a good mix of the tumours that we do. This is the same patient that I've been talking about. So this is the volumetric imaging of the tumour preoperatively. This is the intraoperative study. We always do volume so we can co-register. We see that there is some tumour residuum left. It's great. We get to tell the surgeons, you've got to go back in and take some more out. You've not done your job properly. Carry on operating. So we send them back in to do some more operating and determine what's safe to resect. So this is the, we're reading from right to left here, the preoperative imaging. We've got the tumour here. There's still quite a bit left on the IMRI scan, and we've sent them back in to take some more out. They couldn't get the last bit out because the patient was having language problems at that time, and that's why they were doing to see what they could safely resect. But if we look at the enhancing component, we can see that this is the preoperative imaging, and there were enhancing nodules within it. On the preoperative imaging, all is likely that we've taken out the high tumor. That's the aims of your surgery. I also involved in a lot of research. There's a lot of neuro-oncology research out there. It is often led by neurosurgeons and also neurologists, but they rely on the radiologist to provide the imaging support. So we're involved with previously Golden and now Brighter, which looks at determining whether or not there are subclinical features of brain atrophy or Alzheimer's disease to suggest that maybe the patient has subclinical dementia or small vessel disease, and that might determine why they may not respond to radiotherapy as well. I've been involved in training for impact. So this is the neurosurgical incidental meningioma study. So I've done a tutorial to the neurosurgeons on how to measure tumor volumes. We've got a meningioma study that is been accepted and funded and will be up and running in the near future, which is looking at epilepsy and seizure in meningioma patients. And I also have an MS study as well. So I don't just stick to neuro-oncology, I do other neuroradiology research too. I'm heavily involved in education as well. We have medical students and SAMPs that come to us. I do a lot of SHO teaching. I do radiology registrar teaching. I've contributed to BSNR teaching and grand rounds. I am the chair of the education subcommittee for the British Neuro-Oncology Society. And I apologise, my cat has just knocked something over. And I am the current joint Boulay RCR BSNR travelling professor along with Tilak Das. Sometimes we have a little bit of spare time on our MR scanner, and it's always nice to play and do a little bit of physics. This is a block of aluminium on our 3T scanner, and you can, if you put even aluminium in a very heavy, strong magnetic field, you can induce a magnetic effect within it. And this is the block of the, yeah, it's going, I'm just checking, and you can see that it's slowly just falling. And for the physicists out there, this is known as the lens effect. It's quite good playing with the MR scanner when you get a little bit of time. Oops, let me just. The great thing about neuro-oncology, neuroradiology, though, is the team working. I have a great team around me. We've got really good neurosurgeons, very friendly neurosurgeons, great neuro-oncology nurses, and great neuropathology support as well. And it's team working. I think that's probably the bit I enjoy most as doing neuro-oncology radiology. It is vital that we are part of everything. Okay. And so to summarize, why neuro-oncology imaging is a great career choice. Diagnostic neuroradiology is wonderful. It gives us lots of imaging puzzles to solve. We get to do radiology in color. We've got perfusion maps. We get to collaborate well with the neurosurgeons. We give them advice and support all the way along. We tell them where to go sometimes in their neurosurgical planning, not where to go out the room. Heavily involved in research and education, and team working is wonderful. So if you've got any questions, please. Thank you. And I apologize for my cats.
Fantastic. Thank you ever so much, Sam. Looks like there is a question's just popped into the chat from Connor. Can you see that, Sam, or do you want me to read it?
Let me open the chat bit. Connor, what resources would you recommend for students, junior doctors wanting to learn more about advanced imaging techniques? or just for anatomy in general? Well, the BSNR website's got some good talks on neuro-oncology, and there's a range of speakers on that. ISMRM is another source for really good educational resources for learning a bit about the physics behind it. I think going and speaking to neuroradiologists, because often they'll be quite happy to spend a little bit of time and go through the techniques with you. I mean, they're my best recommendations, really. It's always good to see things in action. So if you want to know a bit about neuro perfusion imaging or DTI sequences, go and have a chat with a friendly neuroradiologist. I think it's the best advice.
Absolutely, I would second that completely. Wonderful. Well, thank you ever so much for your talk, Sam. And certainly one of the themes that I'm hearing emerging through these talks is the fact that radiologists work in a team and actually really enjoy working in a team. I'm sure that's something that we're probably going to hear again in some of the later talks. So we've got one more talk before we have a coffee break. And so I'm delighted to welcome Dr. Hannah Stockley, an interventional neuroradiologist based in Manchester, I believe. And Hannah's going to talk to us about the world of INRs. Over to you, Hannah.
Sorry, I hope I'm going to be able to get my presentation up. We had some slight problems this morning getting it open. Sorry. Sorry, I'm not sure why it's not sharing my screen.
Okay.
Sorry.
I mean, if you want to email it across, so we can do the Chris Whitty thing in the next slide.
Yeah, that might be sorry, that might be easier. I think it's where I've upgraded the Zoom, it's not allowing me. So sorry, do you want to have some discussions? I'll just email it across to you.
Okay. So while we're doing that, are there any other questions that anyone has? Any other?
I think I've got some direct questions
Okay.
to me. So how do you get credit towards training during your PhD? Was it doing on calls, and how much credit do you get? Well, it depends. Oh, let me put my camera back on. It depends on what your PhD is on. I regularly attended the neuro-oncology MDT, so I had neuro-oncology radiology reporting throughout my PhD. I did actually do some locum on calls and some locum plain film reporting as well, which gave me, I think they gave me 12 months of credit actually for my 3.5 years PhD. It was very generous, but it was a very clinical PhD doing a lot of imaging. And the other question that someone's put to me is, in clinical practice, is the neurosurgical approach that is recommended by neuroradiologists usually the one that gets done? Well, that's a bit debatable. It is, if we're using tractography, often it's a combined discussion between you, showing the images together, and we share it in the MDT. I mean, it's part of the MDT is the group of neurosurgeons together with the single neuroradiologist discussing the approach, showing the images in lots of different planes to try and discuss their approach. And the neurosurgeons, often 2 or 3 of them, will come up with different approaches and they'll decide together based on the imaging. But I think that's the other questions that I had. How are you getting on, Hannah?
Hopefully I've sent it to Rob. Sorry.
Okay, I'm just waiting for that to arrive.
It's been one of those kind of mornings. Is that all right? Does it come?
It's presumably on its way. Not quite arrived yet. So just while I'm waiting for Hannah's presentation to arrive, I'll just also mention that we're very lucky this morning in that we have both of the current BSNR de Boulay travelling professors speaking. So you've just heard from Sam, who's one of the pair of de Boulay professors. The other, Tilak, is going to be talking to us after the mid-morning break. And the de Boulay professors are chosen from the British Neuroradiology community to deliver talks around the UK to various radiology training schemes. Normally, if there's 2 of them over a 2-year cycle, delivering sort of 10 to 12 talks. So it's wonderful that we managed to pull both of the current de Boulay professors in to talk to you all this morning. Now, for some reason, it's not arrived. What
I was going to say, would Tilak like to go, and I'll have a play and then present after the coffee break?
I think that would make sense, if that's okay. So, Tilak, are you okay to talk? So while Tilak loads his slides up, so Dr. Tilak Das is a consultant neuroradiologist in Cambridge, who also practices, he does a lot of radiology. And so he will tell you a little bit about how head and neck imaging part fits into his role as a consultant. So over to you, Tilak.
Hi everyone. Sorry, just give me a second to get myself sorted out here a little bit. Let me share. Okay, are we good?
Yeah, looks good.
Great, thank you. Right, so yes, my name's Tilak. I'm Tilak Das. I'm a consultant neuroradiologist and head and neck radiologist in Cambridge. A bit like you heard from Tom. I do a little bit of both. So we'll talk today a little bit about head and neck radiology. I'm not going to go through sort of very specific cases so much, but I'll start with how I ended up where I am, and then sort of talk about why, what the community, the head and neck radiology community, likes about head and neck radiology, and use some cases to illustrate that, a little bit. Great. All right. So this is how I started. It all started with zebrafish. So these are, you'll have come across them, I'm sure already, but a model organism for studying developmental biology. And when I did a BSc or BA here in Cambridge after preclinical school, and the lab I was in was a developmental biology lab looking at development of the retina. And we use zebrafish for our experiments. And as you can see from some of these videos, they're quite transparent, especially at that early stage. And right at the end of my BA or BSc, I came across someone else doing some experiments on these, and they showed images like these. And essentially, it's a stain that stains cell membranes, and you can see every single cell in the developing organism. Of course, the more difficult bit is trying to work out what's actually going on. But here's a cell, for example, that's dividing. So then I realized that actually I might quite enjoy doing this for PhD. So I stayed on to do PhD before clinical school. And we ended up looking at these kinds of organisms where we had fish that expressed green fluorescent protein just in retinal ganglion cells, certain cells in the retina, and they're the ones that throw off axons to go to the tectum, and ended up with images like these. And really, although the PhD was, specifically about, a specific question about cell fate and so on, what actually I really enjoyed was the imaging. And this gave me the imaging bug. And so throughout clinical school, I stayed interested in radiology. So after PhD in clinical school, I decided not to, at that stage, pursue academia. I'm not a great writer, and so I'd had enough of that. So I did an MRCP and house and SHO jobs. Then ended up doing my radiology training in Nottingham. We had a great time. Loved it there. I did an ACF there as well, but academic clinical fellowship, but again, decided to stick to clinical work. Then after my exams, my radiology exams, I went to Cambridge for a neuroradiology fellowship. Did that for about a year and then wanted to do some further training. So for that, I did a fellowship in Toronto. And this is where actually my head and neck training really came together. So this is Princess Margaret Hospital, which is a renowned sort of oncology center. And they do a lot of head and neck work. And what it meant was, as we did our rotations during our fellowships in neuroradiology, it meant that we got to do very intensive 3-4 months or more of just head and neck radiology. And that's when I realized actually an area that I wasn't so familiar with before, that I actually really enjoyed it. So I came back to Addenbrooke's after that to become a consultant. So I have my thoughts about head and neck radiology, but I decided I would ask the community. It's a small community and quite close-knit. And I asked them what everybody thought of their jobs. This is, of course, very biased, but what you're going to see now is a word cloud. And although it's biased, I think it's absolutely true. So, and you can see some of the themes that have come out now. There's a huge number of words, so I'll just pick out a few themes from this. So the largest one here is complex and challenging. There was talk about sort of being head and neck being both oncology and neuroradiology, a lot of anatomy. And indeed, I think it is, the challenge makes it really interesting. So we use a lot of different modalities, right from plain films to a lot of ultrasound, of course, given that the neck is so accessible, and ultrasound guided procedures. And then CT is sort of our workhorse. And despite, a lot of head and neck work being related to soft tissues, you get great quality imaging from CT and can really help patients with that. And at the same time, MRI is also extremely useful. And so here's a very nice quality MRI of a patient with very large sort of neck lymph nodes, and we're searching for the primary cancer. And then I'm not a nuclear medicine specialist, but I work with them very closely. And we, a lot of head and neck centers will be needing to do a lot of PET scanning. So PET does not stand for paint every tumor. It stands for positron emission tomography, of course. But again, a super useful tool for head and neck radiology. And here's a patient where you can see abnormal uptake in one side of the neck from lymph nodes, and that uptake in sort of more towards the midline, which is the primary tumor in the pharynx. So we use a lot of modalities, and the head and neck is a small space, and there's a lot of anatomy. So right from bones to nerves, muscles, blood vessels, and everything. And we look at diseases of all those different areas. So that makes it super interesting. If you really understand the anatomy, then actually it unlocks a whole world of sort of understanding diagnoses and being able to help patients. And the head and neck radiology is not just about sort of pharynx and larynx, but it goes right from sinuses, orbits, floor of mouth, all the way down to the clavicle. Doesn't seem like a big area, but there's a lot going on there. Although cancer is probably the sort of biggest sort of workload that we do, there's a lot more to it. So there's cancer, there's infection, abnormalities of cranial nerves, which require quite careful imaging, abnormalities of the orbits, of course, CT for things like temporal bones. So a lot of very delicate and small anatomy that needs to be understood and is great fun to do. And sometimes you come across patients with earrings in their ears, and this is what I call odontogenic otalgia. So this patient has a tooth stuck in their ear. I think she was waiting for the tooth fairy, but somehow that tooth got lost and unfortunately she never came. So what other themes can we pull out here? There's all these words about fascinating, beautiful, interesting, amazing, and I absolutely agree with that. And I think that's really one of the important facets of what makes this job fun. And by coincidence, just yesterday or day before yesterday, I came across this report, which is a survey of scientists, biologists and physicists, and whether they saw, it was about their well-being, but it was also about whether they noticed beauty in their work. And what the researchers who did this survey sort of concluded, or one of the things was that we find that more frequent experiences of wonder, awe, and beauty are associated with high levels of job satisfaction and better mental health. And this is the point I wanted to make here, is that every single day, there's just some amazing imaging to see. And so here, for example, is a very bog standard MRI of the internal auditory canal, MRIAMs. And if you remember, inner ear is sort of your cochlea and semicircular canals. And so if we scroll through that, that's what we're seeing here, just in cross section. But now with, depending on how the imaging has been done, you can manipulate that, so rotate the image, thicken it up, so you project a bit more. And now you can see that beautiful cochlea and semicircular canals there. Obviously, you can then manipulate that image. And even though this is a completely normal scan, every single time I do this if I occasionally check the 3D structure here, I just get a little joy out of it. Okay, and similarly, you can take a sort of bog standard CT scan and do something like this. So this is a rendering of a patient with a very large goiter. This is just a thyroid goiter, but it's extended down into the chest, so it's behind the sternum here, which you can just about make out as the orange structure. I've left the ribs on for a bit of context, but then here's the heart, and notice how this goiter extends sort of in front of the aorta and insinuates around the large vessels. So again, I mean, this does take a little bit of time, but it's something that I quite enjoy doing. And the other side of this is some of the logic that you have to apply by understanding the anatomy. So here, for example, are 3 neck lumps, all in very similar locations, slightly different appearances on MRI and on CT, but they could be coming from the same place. But actually, if you look, I'm not showing you the stacks here, but if you look through the imaging, what we find is that the way other normal structures are sort of displaced by these masses tells us where these masses have come from. So this one has actually come from the parotid gland. So it's moving things across medially. This one, a very vascular thing, these are flow voids within it. It has actually come from the carotid sheath itself. So this is a paraganglioma. And it has splayed the vessels and then moved things around, but it hasn't come from the parotid gland. And this one has moved the vessels back, so they're not pushed sort of anteriorly. It's come from anterior and it's pushing other structures back, and it's come from muscles of mastication. And this is a young patient. That then tells us that one of the most likely things here is a sarcoma. So these 3 entities are treated in a completely different way. So you might say, well, all you need to do is do a biopsy and then work out which one is which. But actually, even to do that biopsy, you want to have a good idea of what these things are beforehand. So the surgeon needs the radiologist to help with that, that sort of location and really shortening the differential diagnosis. So I enjoy that aspect of this job too. Of course, patients are the center of everything we do, and a lot of my colleagues have sort of mentioned that in their comments to me. And that might be because, you know, with head and neck radiology, we do a lot of ultrasound, so we're in direct contact with the patient. This is a patient who's had a neck lump biopsied, And so for the patient, this might be the first attempt at a diagnosis for something that's really worrying them. So it may be quite memorable for them. It might be the beginning of their pathway, a long pathway of treatment of cancer, for example. So that time is very important. On the flip side, it's actually a very good way of being able to reassure patients that that neck lump that they've found is actually completely benign. And we can do that straight away at the time of the scan. And often you'll see sort of palpable relief in these patients. They're extremely nervous as they come in, super relieved when they leave, and that can be very satisfying to be able to help them in that way. The other thing that we can help patients with is sort of prognosis, and what can be quite difficult sometimes. So in this case, there's a patient here who has a small tumor, which you can't see very well on this particular type of scan. It's a contrast enhanced MRI, a small tumor just on the cheek on the left. But when they have their MR, what we notice is particularly on the coronals that I'll show you now, is you can see this sort of abnormal enhancement. So this is the cavernous sinus. We're going into the skull base here. And this is the coronal view. And what you'll see is that here's the tumor of the cheek. And you can see this bit of thickening and enhancement, which you don't see on the other side. And that's going under the orbit. That's the infraorbital nerve that supplies the cheek. Goes back, and you can still see a bit of thickening and enhancement there. This round profile here is foramen rotundum. So if you remember foramen rotundum, that's where your maxillary division of the trigeminal nerve goes. So that's thickened compared to the other side. Go a bit further back, and then you come to sort of Meckel's cave and cavernous sinus area. And then you notice that actually that abnormal thickening then goes down here into the masticator space, and this is foramen ovale. So by understanding the anatomy, we can now understand that this tumor has spread along the nerves back to the source of the trigeminal nerve, and then spread down various branches, including the mandibular division. So this patient has something called perineural spread of their tumor. And what that means for them is that although the prognosis is poorer, it does mean that they wouldn't undertake unnecessary, very morbid surgery, because that would not be curable. So this kind of finding, which is often done by a radiologist, is very, very important. And then finally, you'll notice some words here about collaboration, working in a team, a sort of tight-knit family, working with surgeons. And indeed, a lot of the work we do are done very closely with the surgeons, with the oncologists and medics. And so I take part in a skull base MDT, and this is the kind of case that we might see there, and we're helping them decide what to do with this huge meningioma. Also do the head and neck MDT. But the important thing here is that one is that brings a lot of job satisfaction, the interaction, getting feedback, and learning. So constantly learning by speaking to our surgeons. I help our oncologists with their radiotherapy planning. So we'll go through their radiotherapy plans together for head and neck tumors, mainly to help with any sort of intricate anatomy or equivocal abnormalities, for example. And that's a fun part of the job too. And here's another way where we help. So this is pre-sinus surgery. These are different cases, but just illustrates the point. And what we're looking at here are small anatomical variants that might be important for a surgeon. So here, for example, is the orbit. And you see this little canal here. That's an artery called the anterior ethmoidal artery. It comes off the ophthalmic artery to go and supply sort of sinuses, mucosa in the sinuses. And when the surgeon goes in here and they're taking out various bits of bone to try and remove obstructions to obstructed sinuses, the one thing they want to do is try and avoid this, because if this is not obvious to them, it just looks like a bone. And that's the bone that you're going to see here. And what you'll notice is that as the surgeon goes in and they crack open that little bone, it doesn't take much for blood to start gushing out. Okay, and so the radiologist's viewpoint here is the important role here is to warn them of these kinds of potential risks. So I should say that I this word cloud was made from comments and thoughts of my colleagues in the British Society of Head and Neck Imaging. So that'd be worth looking up if you're interested in head and neck radiology, because they encourage students and doctors just starting out to contribute to conferences and so on. But I hope that's given you a sort of flavor of why we love head and neck radiology, why it is a fascinating area and something certainly worth considering. Here are some resources that you might find useful, not just necessarily for head and neck, but for anatomy in general at any level. This is a great one for head and neck radiology, learningheadandneck.com. And so is this one. They all have quite good lectures explaining a lot of important concepts. Radiopedia, of course, has a lot of information. And I sometimes use Biodigital, which is a freely available anatomy model, quite detailed and pretty good for teaching. And of course, you've heard about resources at the BSNR, but also have a look at BSHNI. Great, that's all I've sort of decided to say, but if you have any questions, you can reach out to me on Twitter, of course, or you can ask me now.
Okay, wonderful. Thank you ever so much for that, Tilak. That's some beautifully illustrated talk, and it's a world I don't dabble in. I don't do much head and neck radiology, so it's lovely to see some cases to remind myself what it all looks like. So, that was great. I can't see any questions in the chat. Not sure if any come directly to you, Tilak. Otherwise, we are running a little bit behind on the program, and I don't want to sort of keep people beyond the end of this scheduled slot. So what I suggest we do is, if we break now, maybe what do you think, Seth? Should we say to try and reconvene at 11:55? That gives people sort of 9-10 minutes to stretch their legs, get a drink if they want, and then we pick it up again from there. We can also test Dr. Stockley's slides, just see if we can get those to load. If not, I've now got a version of them that I can show from my end. And any other questions you want to drop into the chat, please do, and we can always pick them up after the break. Okay, so is that okay, Seth? Yeah, okay. Wonderful. So should we aim to reconvene at 11:55 then, please? We'll get going again. Thank you. So, Hannah,
let me see if I can make it work.
Okay.
Life as an interventional neuroradiologist or life as a neurointerventionist. So I work I'm a consultant at Manchester Centre for Clinical Neurosciences, which is based at Salford Royal Hospital. Okay, next slide. So I'm going to talk today. So this is an image of the not so new building actually at Salford Royal now. This was finished, I think, in about 2012. They are building a new building, which is called the Acute Receiving Centre, or will be known as the ARC. So we'll be next to this. But today I'm going to talk about sort of what I do, why I do it, and how I got there. Okay, next slide. So this is where there are quite a lot of animations. So if you just click through about 4 times, thanks, Rob, sorry. So some of these celebrities have benefited from interventional neuroradiology. So we have Emilia Clarke from Game of Thrones, Cy King, who's a hairy biker, Sharon Stone, and some of you may know Karen Brady from The Apprentice. And they've all had brain aneurysms. So an aneurysm, as I'm sure you know, is an abnormal bulging or balloon in the wall of a blood vessel. And the main risk from having an aneurysm is that it can rupture. And about 2 to 3% of the general population have a brain aneurysm. Most people don't know about it. As I said, the main risk is a risk of bleeding. The other risk is that aneurysms can enlarge and can cause mass effect if they reach up to sort of 2 to 3 centimeters. And the main way that we treat aneurysms is either an endovascular approach. So I'll talk about that in a minute, where we treat about sort of 85 to 90% of aneurysms by going through the blood vessels, or open surgical clipping. So what's the difference between endovascular and surgery? So everyone generally knows what surgery is, but sometimes when I say endovascular or intervention to medical students, I get sort of slightly blank faces back. So an endovascular approach, yeah, if you just click, thanks Rob. So we use the blood vessels to navigate our way around the blood, around the body. So it's we gain access either into the femoral artery, or more recently, we're gaining access similar to the cardiologists into the radial artery, and it's indirect visualization. So we look at what we're doing on a monitor, as opposed, so it's a catheter mediated actions are performed outside the body. And it's a minimally invasive alternative to surgery. So we're basically manipulating wires and catheters down in the groin or in the near the wrist. It's a bit like playing a video game. You have to have reasonably good hand-eye coordination, because you're not actually looking at what your hands are doing. You're looking at the wires that you're turning, and you're looking at the actions on a monitor using fluoroscopic X-rays. And this is different to surgery. Obviously, surgery is direct visualization, where we have open exposure of the brain. In management of aneurysms, it's vessel dissection and manual manipulation. And of course, it's a very invasive procedure. Okay. So this is all performed in an interventional or angiography suite. So we have biplane X-rays, so we can visualize the vessels in two planes, so front to back and side to side. We inject dye into the blood vessels through the catheters, and then we take successive rapid images to create an angiogram. And our angiogram looks a little bit like this. It's not quite as well set out. I think we have a picture a little bit later of what our room actually looks like. And I thought I'd talk a little bit about the history of the development of endovascular techniques and aneurysm treatment, just because I know this is sort of neuroradiology, but also thinking about neuroscience, and there are some neurosurgeons and neurologists on the call. So the first cerebral angiogram was actually performed in Portugal, in Lisbon. It was pioneered by a team headed by a physician called Muniz, and it was direct puncture of the carotid artery and then injection of a radioactive dye. So they were actually injecting into blood vessels radioactive material and then taking X-rays. In 1937, there was the first successful clipping of an aneurysm, and we know that microsurgical techniques have really steadily evolved since. And in 1941, neurosurgeon Werner et al. Reported puncturing the wall of an exposed brain aneurysm. So this was, they'd got open access, and then they put a needle through the wall of the brain aneurysm, and they inserted 9 meters of silver enameled wire and then took an X-ray of it. And it actually doesn't look that dissimilar to some of the images that we recreate today. But obviously, interesting technique. So in 1953, the first femoral catheter angiography was performed by Seldinger. So a technique of puncturing a vessel or puncturing structure with a needle, inserting a wire, and then taking a more permanent structures such as a sheath or a chest drain. It's Seldinger technique is something that's used across medicine, and that was first used to perform a femoral catheter angiogram in 1953. And then in the mid-60s, they started introducing microcatheters into the brain, but these were really quite rudimentary. And then in the early 70s, we get the first description of proper sort of endovascular treatment of an intracranial aneurysm. And this was by using a vascular catheter and detachable latex balloons. And these were used to essentially either occlude the blood vessel that the aneurysm was arising from, so essentially vessel sacrifice, or guiding them into the aneurysm itself. Yeah, if you just click there, Rob, yeah. So we can see that it sort of, in some ways, appears relatively elegant, certainly sort of trying to navigate balloons into aneurysms, but you actually got relatively poor occlusion of the aneurysm. And just on the next image, you can see that although the balloons here look reasonably sizable, they were actually tiny and literally sort of a couple of millimeters and very fiddly. to actually get in and navigate into the aneurysm. Okay. And in 1989, Hilal et al. Reported the first use of short pushable coils. So coils that were similar to those used in peripheral vascular disease, peripheral vascular intervention. They had little sort of fibers on them in order to encourage thrombosis, but they were really relatively stiff. If you just click through all of this, actually, Rob. So it was difficult to get dense packing of the aneurysm. There was a risk of rebleed, especially in acutely ruptured aneurysms. And so there was still this sort of quite persistently high morbidity and mortality that the neurosurgeons really didn't feel was worth the risk, when in their hands they could clip an aneurysm. And the adage today is that a clipped aneurysm is a safe aneurysm. Furthermore, the coils weren't retrievable or controllable. So once they were pushed in, there was no way of getting them back. And then in 1990 or sort of late 1980s and in 1999 over in the university in UCLA, Guido Guglielmi, who's this chap pictured here, started to develop electrolytic detachable coils. So he developed coils that were attached to a pusher wire, and therefore they were retrievable. And he coiled the first aneurysm with them in March 1990. There were trials throughout the US. They started to be widely used in 92 in Europe, and then they were approved by the FDA in 1995. And a study was undertaken called the International Subarachnoid Hemorrhage Aneurysm Trial, which really in aneurysm treatment was the game changer. And that was published in 2002. And that showed, that was looking at, it was a randomized control trial looking at the management or treatment of aneurysms, acute aneurysms, treated either by coils, so by the retrievable coils, or by open surgical clipping. And it showed that there was a significant reduction in morbidity and mortality if aneurysms were treated endovascularly. And so that was really sort of the biggest, and I would say the first sort of big game changer in endovascular therapy and interventional neuroradiology. And of course, there was development of intracranial microcatheters and support guide catheters, as well as coils throughout the 1980s and 90s. And as you can imagine, in sort of 1990 to 95, there was a big boom in coils. There were development to target different characteristics such as softness, length, shape, diameter, etc. And that development hasn't changed. I mean, I've been practicing interventional neuroradiology for the last 12 to 13 years, and the advances that I've seen in technology throughout that are massive. If we see the first image, that's sort of a standard, nice saccular berry aneurysm. It's nice to get a single catheter in, deploy some coils. They're all held by the neck of the aneurysm. That's a nice, if there's a straightforward aneurysm, that's what we would call straightforward. But they don't all look like that. In fact, relatively few of them look like that. And so we can use other adjuncts. So initially balloons were developed to help support the coils. So as an architectural support, we had stents develop. So if you just click through it, yeah. So we have stents which can either be a laser cut stent, so they're deployed within the blood vessel, and they are a scaffold to help keep aneurysms within, coils within the aneurysm. We've moved on to, we also have flow diverter stents, which have a higher density cell structure, which are, by their name, they divert flow, so you can use them with or without coils. They're essentially a way of reconstructing the vessel wall. We've got various sort of neck support structures in the bottom right-hand corner. It's called a P conus and a P canvas, so they're sort of different structures that can help keep coils within the aneurysm. And then we sort of go slightly back to looking at intrasaccular devices, so almost going back to what can we put in the aneurysm, a bit like the balloon, but that's a little more controllable. And we've moved on to devices called the web, which is a braided, so it's an endovascular bridging device. So it's a braided device that sits in the aneurysm and causes thrombosis. And then in the last couple of years, there's sort of a new device called Contour, which is in the top right-hand corner, which is essentially sort of a cut-off web that does a similar job. So technology has really advanced throughout the last 20 years and continues to do so. So I thought I'd show some cases. So here we've got CT scan. If we just click through those images. So this is an unenhanced CT scan. We can see that there's subarachnoid hemorrhage. So from this, we would then go on to do a CTA to look for an aneurysm. So the commonest cause of subarachnoid hemorrhage is actually trauma, but then the next commonest cause is aneurysm. So we do a CT angiogram. We can do 3D and volume rendered reconstructions, and that can show us the shape of the aneurysm, the morphology, the neck, which vesselets are rising from. And then we take the patient up to the angiography suite. They're placed under general anaesthetic. They're under GA because they need to lie still for quite a length of time. We can also monitor their blood pressure. So they have quite invasive monitoring during the procedure. Here we can see an angiogram. So we've injected dye into the right internal carotid artery. It shows us the angiogram. It also shows how good the technology that we get and the images that we get from CT angiography to be able to plan the procedure. So for this, we would take a guide catheter from the femoral artery up into the internal carotid, and then we can see there we've got a single microcatheter in the aneurysm, and we're starting to deploy coils. They're detached, and you essentially just continue to deploy coils until there's no more contrast in the aneurysm. So that's a really good result angiographically. Excuse me. And we have another case here. So again, we can see that there's some hyperdensity just around the brainstem. We've got some prominence of some early hydrocephalus, and CT scan and 3D rendering shows that that's looking from the back. So we've got an aneurysm of the tip of the basilar artery. That's quite lobulated. So that was taken again to the angio suite. So this time it looks like it's flipped around, but that's because of the manipulation that we can do of the CTA. So we can look at it front to back or back to front, but in angiography, we always look front to back. So again, we've got microcatheter in the aneurysm, deploying some coils, but we've also got a balloon in the left P1 segment, so slightly wide-necked. So it was felt that a balloon would help just to support those coils. And I think the next image we can see that's the wire and the two markers of the balloon. So there's a little balloon between those two markers that's inflated and deflated as the coils are deployed. Okay, so that was the end result. And then we do follow up with MR imaging. So we do an MR angiogram at 6 months and at 2 years. And that's a really nice result for the patient. So their aneurysm is completely occluded. This is a lady who's got multiple aneurysms, because we can see that there are aneurysm clips from previous surgery, and she had this sort of slightly irregular aneurysm arising from the left P1. There's also a small bulge arising from the basilar tip, but the plan was to treat the aneurysm of the left P1. And then some of the stents that we can use, they're not flow diverting, but they sometimes have flow diverting properties. So she had a stent inserted from the left P1 into the basilar artery. We had a microcatheter was put into the aneurysm before the stent was deployed. We call that jailing. So you deploy the stent and then you deploy coils into the aneurysm, and at the end you remove the microcatheter. So we can see the result there. So we can see our previous aneurysm clips. We can see the markers from the stent and then the coil. And that was the end result. So this is a bigger aneurysm. So as I said, aneurysms can range from sort of 1 to 2 millimeters to 2 to 3 centimeters. So this was an incidental finding on a lady who had some, I think, left retroorbital pain. So she's got a large paraophthalmic aneurysm. And we decided, although this comes down to quite a nice neck, and we could just do a coiling of the aneurysm. So we put some coils in. We also felt that we'd take a slight belt and braces approach and put in a flow diverting stent. We know that paraophthalmic aneurysms can have a tendency to recur. They can be slightly tricky to get a really good dense packing. And so we deployed coils and then a flow diverter. Yeah. So sometimes they can be a little bit tricky to see, but I think hopefully on these images, and as Rob has kindly pointed out, we can see that there's the microcatheter, and we deploy the stent, and we get good follow-up that the aneurysm remains occluded. Next, so this is a basilar tip aneurysm. So we can see that that's a web device. So that's now a device that is inserted into the aneurysm. It's actually in this particular example, it's filling the aneurysm beautifully. That's sort of a perfect example. They don't always look like that, but they've certainly been a good advance, particularly in treating wide-necked aneurysms. If we don't want to put patients on dual antiplatelets, if they need stents, they have to have dual antiplatelets to minimize thrombosis. Different practices occur in different countries. So some patients might be on aspirin for life, some patients might be on aspirin for a year. But there's always a risk of hemorrhage whilst they're on aspirin. So webs have been good for treating wide-necked aneurysms. And these are a few, so that's sort of thinking about aneurysms. These are a few celebrities who I believe have had ischemic strokes. And so I thought I'd talk about interventional neuroradiology involvement in the management of ischemic stroke. And as I'm sure you're all aware, ischemic damage is caused when a vessel is blocked by a small blood clot and the area of the brain beyond that is starved of oxygen and other nutrients. And we know that similar with myocardial infarction, the sooner that you can recanalize the vessel, either pharmacologically or physically, then the less damage can occur. And it was slightly sort of by accident that thrombectomy for stroke sort of came about. One of the complications of aneurysm treatment is that we can get small emboli within small clots form within the catheters, and clinician, an INR, had a small clot form. It got transported into the middle cerebral artery, and he wanted to open up the vessel and thought, what do I have that I could possibly open it up with? They had stents on the shelves from aneurysm treatment, and they got the clot out. And that was really sort of the first thrombectomy that occurred. So it occurred by accident. But this is what we see. We know that pharmacological treatments work, but getting the clot out physically with a stent is sort of again the game changer recently. So it's important to remember though that it's not an overnight phenomenon. Next slide, thanks Rob. Okay, and just click. And since 1995, really the gold standard for acute ischemic stroke has been IV TPA. And obviously that was initially within 3 hours, and then that time window has been extended to 4.5. Within a few years of this happening, interventional neuroradiologists, because they like to advance technology, started to experiment with delivering TPA at the site of the vascular occlusion. So through microcatheters, injecting IA TPA to see if clots could break down. In 2004, there were 2 devices called the Mercy device and the Penumbra device, which would be inserted through the clot and then sort of used to agitate the clot, and you would aspirate just with a 50 ml bladder syringe as you pulled everything out. We started at Salford, we started performing endovascular treatment in 2007. And then stent retrievers were approved by the FDA in the US in 2009. So as we see sort of towards the right-hand images, they were very similar to stents that we would use for aneurysm treatment, but they weren't detachable. So they were on a pusher wire and you would pull them out. And then in 2010, multiple randomized control trials commenced looking at IV TPA only versus IV TPA and endovascular treatment, primarily using stent retrievers. And in 2014, MR Clean was published, was rapidly followed by 4 others, and then a number of ongoing trials were halted as equipoise was lost. In 2018, the NHS commissioned services for thrombectomy, and as of the 1st of March in 2022, Salford now offers 24/7 thrombectomy services. So we've been offering 7 days for the last couple of years, but we can now offer 24/7. So what happens when our stroke patients arrive? So they call an ambulance, the stroke team are alerted so that they're on their way. And then we've basically said patients should be eligible for thrombectomy until proven otherwise. So if they're within 4.5 hours of onset, their age is more than 18, stroke score more than 5. If they're relatively well beforehand, we allow them sort of up to 2 MRS points. And then if they're suitable either for IAV, TPA, plus or minus thrombectomy, or if they're ineligible for IV TPA, such as they've had recent surgery, or if it's a posterior circulation. So they go straight to the CT scanner, basically ASAP, they get imaged within 20 minutes. And if there's no hemorrhage, they have a CTA performed. We also use artificial intelligence. So we have a package called Rapid that the images are all pushed to, which we'll have a look at something that we call the aspect score. So that's basically an assessment on the unenhanced CT brain of how much damage there's been to any vascular territory, particularly of the MCA vascular territory. And it also can predict or can analyze whether there's a large vessel occlusion. It's not so good at looking for the more distal occlusions or for posterior circulation. So we do have to look at the images. So then if Rapid pops up, and if one of our diagnostic colleagues also has looked at the images and alerts the stroke team that there's a large vessel occlusion and they fit the previous criteria, then they're brought straight up to the interventional suite. So this is an image of our angio lab. So it's not too different to the one I showed earlier. Just we've got some very smiley staff there. Can't say that we're always quite so relaxed, but as previous people have said, I work with a great team. So I'll just show an image. So this lady was brought in. She'd had a sudden drop in GCS, a 55-year-old lady, dropped her GCS to 8. She'd had CT scan initially, because initially there wasn't a concern about whether there was a possible basilar occlusion, but her plain CT showed that she had a small area, a small dot of brightness in the region of the basilar tip. So she went on to have an immediate CTA, and actually I think it was our CT radiographers who pointed it out to the stroke team. So again, it's sort of all members of the team are involved in neuroradiology, both diagnostic and interventional. And her CTA showed that she had occlusion of the basilar. So within 3 hours of dropping her GCS, she was up in the angiography suite, and we can see that there's no contrast beyond the mid-basilar portion. And so that's a microcatheter navigated beyond. So we're basically going blind through the clot, navigating using our knowledge of neurovascular anatomy that we've gained by doing aneurysm work. We navigate and we deploy a stent. Also nowadays, we can sometimes we just use aspiration catheters attached to a mechanical pump. And sometimes we can remove a clot literally just by sucking it out. In this case, we used a stent, and we can see final angiography. We have great results. The next image. So we can show that I think within 2 passes, her basilar was completely open, and she woke up in theatre recovery absolutely fine, as she had been sort of 3 hours previously. So it's certainly life-saving. It's definitely life-changing. The evidence that has been produced is some of the most powerful medical evidence, as the number needed to treat is 3. So there's a lot of work obviously going on in the background in order to try and expand services within the regional neuroscience centres to 24/7, so that everyone has access to this treatment. So obviously I've talked a lot about stroke thrombectomy. I've also talked about aneurysms, but that's not the only thing that I deal with. We can see that there's another large area with regards to AVMs and dural fistulas, and diagnosis and management and treatment of those. Similarly, tumour embolization. So for example, yesterday I spent about 6 hours treating a 21-year-old who's got a large, highly vascular nasal tumour, who's having a second operation next week. So we took him down to the CT scanner, put needles directly into the tumour, took him back up to the angio lab, and then injected a liquid embolic, and then occluded some branches of his external artery. So some days are nice straightforward aneurysm, some days are thrombectomy, some days are a little more complex. We also have some overlap with extracranial work with some of the interventional radiologists, And then we have vascular spinal work, so that's dural spinal angiograms, management and diagnosis of dural fistulas and AVMs. We've also got quite a large practice within Salford of spinal orthopedic surgeons who do a lot of spinal resection for tumours, and so they frequently ask us for tumour embolization, and then also a couple of my colleagues do quite a lot of non-vascular spinal work as well. So my typical working week, although this has changed slightly recently, so majority of my work now is managing hemorrhagic or ischemic stroke. So out of a normal week, sort of 8 sessions, including the on-call, because where we've gone to 24/7, there are 6 of us. So it's a reasonably heavy on-call burden, but the service is only just taking off, so we'll see how that goes. So generally I have 1 day a week, sometimes it's a Monday, sometimes it's a Friday in the angio lab, so that's now a long day, 8 till 8. I also take part in the neurovascular pediatric service, so once a month either myself or one of my colleagues goes over to the Children's Hospital and performs pediatric angiograms, and we also take part in the monthly pediatric neurovascular MDT, so I have time to prep that as well. The on-call, as I said, has just moved to 24/7. So we're doing a sort of hot week for stroke, which is a long weekend, and then 4 nights. So we're trialing that to see how that goes. So that's sort of what I do. Why do I do it? I think one of the main things we've really heard about this morning is teamwork and patient care. So I really enjoy the patient side of medicine. I love that I get patient contact and that I get to diagnose, but I also get to treat patients, and that I can have a significant impact on patient outcomes. And I certainly see interventional neuroradiology as a hybrid specialty. So I'm part surgeon, part interventionist, part diagnostician, and really enjoy that side of things. I work very closely with clinical teams, as we've all said this morning, and even more so with my small neurovascular team, so fellow interventional neuroradiologists and fellow neurovascular surgeons. Also within the UK, the community of INR colleagues is also is relatively small. There's about 110 of us currently in the country that perform that are interventional neuroradiologists. And I'm also able to have a national impact through involvement with BSNR, but also with UKNG, which is the UK Neuro Interventional Group. And also I've always really been interested in neurosciences, and again, as colleagues have said, there's a lot of innovative research on in neuroradiology. And again, we see these really rapidly advancing technologies within interventional neuro. Okay, so how did I get to to doing what I did? So I went to medical school, so 96 to 2002, and did an intercalated BSc. It wasn't in neurosciences, but I did do a 4th year special study module in neurosciences, and that was really, that was sort of 2000, and that was where I came across interventional neuroradiology as a subspecialty that I discovered that it existed. And I'd sort of generally at medical school wanted to do anaesthetics, and then started my house jobs and got to do some surgery, really enjoyed it, thought I don't want to be an anaesthetist sat at the end of the table, thinking I could do that better. So I started, was appointed to a surgical training scheme. And really I enjoyed all of the jobs that I did, but didn't want to do any of them for the rest of my life. And in the background had always been radiology and in particular interventional neuro. So I applied to do radiology training on the basis that I wanted to be an INR. But again, as others have alluded to, I had to do 4 years of clinical radiology because I was on the old scheme, and then did a 5th and 6th year INR fellowship in Manchester. I then went on to do a post-CCT fellowship in Leeds for a year, and then was appointed as a consultant in 2013 at Salford. So I've now been there for about 8 years. Okay, so I hope that that's a little bit of a run through of brief run through of interventional neuroradiology. I think I could probably spend most of the day talking about it. I think I've hopefully highlighted some of the areas of specialist interest, some of the things that we do sort of day to day, and again, sort of the main theme that I think is running through every talk that we're having is that I work with a great team, and they really we support each other, but we also sort of work in a great specialty. Thank you. Any questions? I think no.
Wonderful. Thank you so much for that, Hannah. I know it's difficult speaking when someone else is advancing the slides, but I thought that was a great team. That was
In neuroradiology, it's all about teamwork.
So I think take one quick question from Connor before we move on. So chat mentioned thrombectomy now 24/7 at Sol. You know what the exact availability is like for every centre? If not, is that a research answer?
So I think there's about 6 or 7 centres in the UK that are currently offering 24/7. So I know the Walton Centre, also within the Northwest, is offering 24/7. There are 4 centres in London that are offering 24/7 thrombectomy. There are 28 regional neuroscience centres across the country. There's been a lot of work put into creating a credential for non-radiologists to perform thrombectomy. There's a lot of political interference in that credential, which is currently ongoing. Sadly, I think the credential as it was started out to basically mirror sort of postgraduate training in INR, and to help people develop both aneurysm and thrombectomy skills, so that it appealed to a slightly wider market. I think unfortunately that's being curtailed, but I'm not quite sure how much I'm allowed to say, because I've been involved in it, so I know quite a lot of the background details. So I don't quite know how much I am or not allowed to partake or whatever. So is it a research question worth answering? It's a question that I think within the UKNG community is relatively easy to answer. As I said, we're a small community. I mean, we're always looking for people to help with surveys. So if anyone was interested in helping with that, because I'm also putting together through my role as secretary at UKNG, trying to put together a workforce survey so that we have a slightly better idea of exact numbers, although we did do a very brief workforce survey. So we know that there's 110 neurointerventionists practicing at the moment.
Okay, wonderful. Thank you ever so much for that, Hannah. We better move on because I know that time is ticking. So I'm now going to hand over to my colleague from Nottingham, Arpita, who's going to be talking about a subject that's also very close to my heart, which is paediatric neuroradiology. So let you tell us all about it, Arpita.
Perfect. Hi everyone. So I'm just going to share my screen, and I'm hoping it's not going to crash the system, because it does have a habit of doing that. So let's give it a go. So Rob, can you see my screen?
Yep, it is now loaded up. Yep.
Perfect. So I'm having to do this in reader mode because it wasn't liking it in presenter mode, but that shouldn't alter the overall presentation. So hi everyone. So I'm Arpita, and as Rob said, I work as a consultant neuroradiologist at Nottingham alongside Rob. So today I'll be giving you a very brief introduction to paediatric neuroradiology as a further subspecialty within neuroradiology. And a lot of what I'm going to say today is going to be repetition of what we've heard from our colleagues earlier on. So the next 20 minutes or so, I will also be talking about what I do during my day job, show you a couple of diagnostic cases. I'll tell you how I got here and a couple of pros and cons about my job. But first, let's start with a couple of myths about radiology as a whole. So firstly, Lots of people think that we live in basements. We don't get out of those dark caves that we do our reporting in. That is not the truth. We can be found anywhere around hospitals, particularly anywhere where they can supply us coffee. Now, very important to have your eye protection on, particularly when they're so important for our job. But jokes aside, we're not just limited to our reporting rooms anymore. Radiology is such a vast, dynamic specialty now. We're often seen in surgical theatres, radiology theatres, up on wards, in clinical areas, doing MDTs. So we're seen everywhere. Next, there's a perception that we work in isolation and we much prefer being on our own, that we're hermits. And again, not so much the truth. We are just being COVID safe. So we're a very sociable, fun-loving specialty. So here are some pictures from my registrar years, which was just before COVID took off. I went to Leeds Radiology Academy for my training. So here is a picture of us back in 2014 when we all started. And here is a picture of us at our Christmas dinner last year. So 7 years apart, we still all regularly meet up and chat. And so it's all about, as you've learned, all about team collaboration, working together. Next, there's this horrible perception that we're grumpy and obstructive characters, really unhelpful at times. And I'm hoping that the talks that you've had beforehand have helped to dispel that myth. But we're the ultimate team player. We interact with so many clinicians and healthcare professionals throughout the hospital. So here's me. This is Despina, a pediatric neurologist. Rob and Simon are neuropathologists, and the rest of my colleagues here are neurosurgeons. So we all go out as part of MDTs too. So you know, we are pretty integral to the hospital community, and we do get on with loads of people. So it is certainly a myth that we are grumpy characters. Look at us all smiling there. And then the biggest perception really is that we sit in front of screens all day, from morning all the way through our jobs to onto computers, laptops, TVs, iPads at night. And the reality is that really, particularly with the recent lockdowns, we certainly have been glued to our screens. So it's really important to, whilst, you know, be dedicated to our jobs, do practice really good work-life balance. And I know a lot of my colleagues have interests outside of work which do take them away from those screens. So I am a full-time consultant at Queen's Medical Centre. As a new consultant, I started on 10 PAs, which is very similar to everyone else around the country. My clinical work, so my reporting, is done over 3 days a week, and I have almost 1 day for SPA. So I only work for 4 days, and I have the equivalent of a day off every week. I am an adult neuroradiology with a subspecialty interest in pediatric and fetal imaging, and I've got on-call commitments. So my job's a little bit different to what everyone else has presented so far, in that I'm a purely diagnostic consultant. I do no intervention. In fact, I don't actually have any patient-facing activities. So I do a lot of reporting, a lot of diagnostic work. And the mainstay of my work is cross-sectional imaging, and that's CT and MRI. I don't do ultrasound, but Rob and our other colleague Adam both do ultrasound in the neonatal period as well, be that cranial or spinal. We all report fetal imaging, and that's fetal MRI. And we also do post-mortem imaging as well as the reporting. There are the MDTs that come with that. And in the pediatric population, that's the pediatric neurology and the pediatric neuro-oncology meetings. And we do teaching alongside that too. So here is a rough draft of my rota. And as you can see, I tend to have most of my Mondays off and most of my Wednesdays off. The Tuesday, Thursday and Friday are quite reporting heavy, interspersed with MDTs on occasion. As Tom said in his talk, I also, as one of the new consultants, have the Friday afternoon hot reporting session, but it's a pretty flexible rota. So a little bit about paediatric neuroradiology. So those of you who've done your peds rotation at med school will have been told that children are not just little adults, and it's certainly true for paediatric neuroradiology too. It is the case because the children from neonates to infants into the pediatric and adolescent age groups, they all have different appearances of the developing brain and the developing calvarium. And children have different pathologies when compared to the adult population. It can be a tough subject. We know that it can be difficult for the clinicians to provide us with the clinical histories or the complete clinical examination. The studies can be quite difficult to acquire, so sometimes the children may not tolerate the whole study. Before the age of 6 months, if we tightly swaddle the baby and put big headphones on them, they can tolerate a full MRI, but after that they start to wriggle, they start to get restless. They can be quite long studies. So we need to think of alternative ways for the children to tolerate the scans. So we may want to do quick acquisition sequences. We may need to make the use of a play therapist, and we'll look at that in a little bit. Or we may have to use anesthetic. Some of these scans can be involved in medico-legal cases, and those are particularly the ones around abusive head trauma, or even those of hypoxic ischemic encephalopathy. And some of these cases are really rare. I do have to get on Google often and pull out the textbooks, and often, you know, trying to make the most of other pediatric neuroradiologists around the country to see if anyone else has seen similar cases. So I'm just going to give you a very quick overview of my workload, really, to see the kind of cases that comes through pediatric neuroradiology. So posterior fossa tumours. Well, tumours as a whole in the pediatric population is something that we get involved with, either new diagnosis or follow-up imaging. These children are closely surveyed with imaging. And as you'll know, in the pediatric population, tumours often are seen in the posterior fossa, and these are probably the 4 most common that you'll see. This is a post-contrast scan, which shows a solid cystic tumour. This is a pilocytic astrocytoma. This is DWI, which shows a very cellular tumour in the midline in the 4th ventricle, a medulloblastoma. This is a T2 scan, which shows a heterogeneous, very plastic, insinuating tumour. This is an ependymoma. And this is a high-resolution T2 scan, which shows expansion of the pons with T2 signal hyperintensity. You can see how it's creeping around the basilar artery there. And this is a diffuse midline glioma. So I'm going to see if I can get you guys to put your thoughts into the chat box. I'm going to give you a couple of seconds. We also see midline tumours, and I'm going to start off by giving you this CT. Has anyone got any ideas what we're looking at here? I'm going to give you about 10 seconds, and Rob, I can't see the chat box, but if you see any of any suggestions, do give me a shout, and I'll give you a couple of seconds before I move on to the next set of images.
Calcified aneurysm?
Sorry?
Calcified aneurysm?
Well, you're along the right tracks with the calcification. So I'm still on the tumours section. So what other tumours may have calcification associated with them?
Meningiomas?
Perfect. In the pediatric population? Okay, let me move on to the next few images, which may help you a bit more. So we can use different windowing with CT to help highlight different structures. So these are our bone windows, which we really use to assess the calvarium, skull base, and facial bones with. But it does show us much better that calcified structure in the midline there. What are we looking at? What do they look like?
Like a teeth?
Exactly, they look like
teratoma.
Yeah, so this is a teratoma. This child had 32 teeth in that tumour. So we do see some unusual looking tumours too. We also see tumours in the congenital period. So the first picture here is quite a gross tumour, solid cystic tumour, which has replaced much of the brain parenchyma. That too was a teratoma, like the previous case. Here's a second case, more subtle this time, and what we're looking at is this mass lesion in the region of the right thalamus, which you can see is causing slight asymmetrical ventricular megaly. And in the postnatal period, we found that this was also a teratoma. There we go. So moving away from tumours, we also see trauma. So I know that you guys have probably all seen a lot of trauma on head scans. And again, I'd like to see if any of you have any thoughts as to what may have caused this child's injury. So these are the bone windows. And as I scroll through, you can see that there's been quite a devastating injury here. There's a lot of left-sided calvarial and facial fractures. See how depressed this bony fragment is all the way into the calvarium. There's a lot of pneumocephalus, a lot of subcutaneous gas. And here's the surface rendered image, and you can see those depressed fragments and horrible fractures. So any thoughts as to what may have been the cause of this child's injury? Nope. This is one that we're starting to see more often now in the pediatric population. So this was a dog bite. We've had a couple come through and they have very, very bad facial injuries. Unfortunately, we also see the non-accidental head injuries too. And in those cases, the findings that we often report on are bilateral subdural collections and subdurals along the falx of different signal intensities with areas of septation in. Now, it can be difficult sometimes, and I'll go down to the cerebellum to help illustrate this point. This is normal brain parenchymal signal here in the posterior fossa. So if you compare the supratentorial grey and white matter, then you'll be able to see that actually both supratentorial hemispheres are really bright. So this child has also had a diffuse hypoxic ischemic event as well. And as I scroll to their eyes, clinically, they had really severe subconjunctival hemorrhages as well. And we can see some irregularities along the posterior orbits there. Here is the child's spine, and they've got a subdural hematoma within their spine as well. So this was a really severe non-accidental injury. Hydrocephalus is something that we commonly see, and we can see it from the fetal period. So this is a fetal scan, and you can see how both lateral ventricles are massive there, with little in the way of development of the cerebral mantle. We've got the postnatal imaging for that patient, which shows, again, very, very large ventricles, deficiency of the septum pellucidum there. And as we come down, quite a small, relatively small looking fourth ventricle. So using our anatomy, we can then suggest that the point of obstruction is along the cerebral aqueduct, somewhere between the large supratentorial ventricles and the small fourth ventricle. And actually, we did some high resolution CIS images, which showed a web along the cerebral aqueduct, which was the point of obstruction. We have vascular cases coming through the pediatric population like we do in the adult population. So here is the DWI images from an acutely restricting large MCA territory infarct, which has also got some changes in the thalamus there, and secondary changes going along the posterior limb of the internal capsule into the cerebral, peduncle and corticospinal tracts, as well as through the splenium of the corpus callosum. Not only do we see arterial abnormalities, we also see venous abnormalities. So this is a neonate with really diffuse venous sinus thrombosis. So superior sagittal sinus. This is a T2 scan, and the sinuses are filled with clots into the straight sinus and the internal cerebral veins there. And this child has subsequently had a left thalamic bleed with blood into the ventricles and hydrocephalus. Infection. Children, like adults, can get intracranial infections. So I thought I'd show you some more unusual cases that we tend not to see so much in the adult population. This is one of the torch infections, congenital infections that children can get, and this is congenital CMV. There are periventricular cysts. there are also further abnormalities going into the anterior temporal horns there. Now, these children can also get periventricular calcification and polymicrogyria, but we're not seeing that in this case. Sorry. The other form of infection that children can get is in the spine, and this is a case that Rob showed me last year of abscess formation and further infection involving the cauda-equina nerve roots and the lumbosacral system there. We've got a lot of enhancement all the way up throughout the cord there. There was a lot of edema on the TT scan, and it's felt likely that the presence of this dorsal dermal tract was the underlying etiology. So that's something that should have been picked up at the baby check to see if there was a dimple there or a tract that extended deep towards the spinal canal. But that was unfortunately missed, and that was a route for infection into the spinal canal. Inflammation, children can also get, but they also get different pathologies compared to the adult population, where we more often see conditions such as MS. So this child presented following a viral illness. Now, having said that sentence, I'm hoping you guys know, based on the history, what condition we would be wanting to exclude. And this is a case of ADEM. So we can see much more eloquently on the MRI these asymmetrical, large, fluffy areas of signal change, which have little in the way of mass effect upon the adjacent ventricles and parenchyma. And again, this is something that we see predominantly in the pediatric population. And of course, we have the congenital abnormalities. This is another fetal scan, which shows a defect in the lumbosacral spine and a fluid-filled sac, so a lumbosacral myelomeningocele. If we look up to the posterior fossa, there's abnormalities there with descent of some of the contents of the posterior fossa into the upper cervical canal. So this is a Chiari-2 malformation. And there are further findings. There's often hydrocephalus and further abnormalities throughout the brain related to Chiari-2. And this was a really interesting case that we saw in the postnatal period of a girl who was born slightly dysmorphic. As I scroll through the T2 axials, you'll be able to see that her eyes are slightly widely distanced apart, hyperthaloric, some abnormalities to the brainstem there. So the thinking very much midline abnormalities. As I scroll further down, we can see there are craniofacial abnormalities. And here's the girl's tongue. It's bifid, it's split in two. The coronal T1 is quite interesting in this case and actually clinches the answer. This is at the level of the pituitary gland. And this is the T1 scan, and we know that there are only a couple of substances that can be bright on T1, including fat, contrast, melanin. One of the other things that's bright on T1 is the posterior pituitary bright spot. And we've got two of them in this case. So this girl actually has two pituitaries as part of her midline abnormalities. So this is double pituitary gland plus syndrome. We're not very creative with our names, but very rare as well. It's the second one I've seen. So I was just going to quickly go through some of the equipment that we use. So Sam's already touched upon intraoperative MRI. So I'll quickly squiz through some pictures, which gives you an idea of how we use it. So our intraoperative MRI is predominantly used for pediatric tumours. So the child, which isn't obviously the case in this picture, will come for their original scan. The surgeons will define the surgery. Now, actually, that's something that's done during an MDT where we discuss the approach, what type of tumour it is, whether the intraoperative MRI is an appropriate means of doing the surgery. So here's the scanner. Here's a door separating the scanner and the theatre. And here is the surgical team doing the surgery. So there we see them. Now, once they feel like they're getting towards complete macroscopic resection and they've got about half an hour to go, they'll give MRI a call and the radiographers will start preparing the MRI. They use a special top, which has a link to a trolley system. The patient will be prepared in the surgical room and an MRI coil fitted to their head, and the doors remain shut. And once everything's in place, once all those checklists are done, as Sam was saying, those doors open, a trolley is clipped into place, the patient is slid onto the trolley, which is slid across those open doors, clipped into place on the MRI scanner, slid onto the MRI bed, popped into the scanner, and they start to have their scan. So these are pictures supplied to us by Philips, who have given us the scanner. So here we see the neurosurgeon looking at those intraoperative scans. Now, that's not really the case. We as neuroradiologists, particularly as pediatric neuroradiologists, are often there in the scanner to help review these images and have a discussion with the surgeons. In this case, there was a small volume of residuum left, so the patient comes off the MRI onto the trolley, back into theatre, and the surgeons complete their surgery. So I'm going to quickly take you through a case that we've had. So here is a posterior fossa tumour, solid, cystic. Here is the post-contrast imaging. So solid enhancing component and a cystic component. So this is a pilocytic astrocytoma. So almost 10:30 in the morning, they come for their pre-registration scan. We don't give them contrast because we're going to use contrast later on, but we use it for registration. So here are two of my pediatric neurosurgeons, Donald and Simon, doing the operation. When they feel like they're ready, they would have given MRI a phone call to say, we're coming to a close. And once everyone's happy, we'll start moving the patient across. So here we are lining the trolley up to the patient's surgical bed. And now it's time for all those checklists, making sure that all the safety boxes are ticked off and those doors have opened into MRI. And here we go, you can see those forms in the hands, making sure that, you know, we've not left any metallic implements anywhere, and the patient's being slid onto that trolley and onto the MRI scanner. And here I am with Dr. Jaspin looking at the images as they're coming through. So here was the pre-op scan and here is the intra-op scan. And you can see that that cystic component has been significantly decompressed. And it looks like they've been a really good attempt at debulking that tumour. We then do the post-contrast scans. So this is what it looked like before we give contrast, and a little bit of high density means that there might be a little bit of blood or surgical sutures there. But we do have some enhancement medially, and it was felt that that was probably residual tumour. So the surgeons go back and they do another surgery and they come back. So now it's almost 5 to 5. And that's the bit that we were targeting. And this is the post-op scan from the second attempt. And we didn't give contrast again, but we feel like they've fully resected that medial component there. So that was an expensive investment, the intra-op scanner. So we did get a kitten scanner. So here's the room for the kitten scanner in the department. And this is what we've got, a little MRI for the children to play with, to get used to what would happen when they themselves go for the scan. You can see, you can pick any patient really to put on the scanner. So the patient's placed on the scanner, you get to push them in. And then you get to watch them having the scan and learn about their story. And this story continues into the MRI scanner. So when the children go in, they can use that as a form of distraction to help alleviate their nerves. And there we go, you can see there's an egg inside Doris there. So the best bits about my job is that I love my job. And I've not actually encountered very many people who aren't radiologists who say that, but I absolutely love my job and I have no regrets. It's such an interesting job and it is challenging. I'm never bored. We could often be the first to diagnose either the child or even the adult. And they can be complex conditions. And as such, we can make a real difference to patient care. It's such a dynamic field, and I'm constantly learning. Every day there's a new gene that I learn about, or a new condition. I'm very lucky that at Nottingham I can do flexible working, and actually I can work quite a bit of my job from home. We've got incredible colleagues of paediatric neuroradiologists through the country, as well as internationally, and we can use them to help us with cases. There's often been times that I've called somebody else from a different centre for an opinion on a scan. In fact, just this week I called Lal for opinion on a spinal on a CSF leak. So you do pull on your colleagues' expertise from around the region. And I work with some really incredible colleagues. So who do I work with? Well, within radiology, other neuroradiologists. So in my department, there are ENT radiologists and adult neuroradiologists as well, and interventional neuroradiologists. Other radiologists, body, MSK, pediatrics and vascular, and our other healthcare colleagues, radiographers and sonographers, some of whom I've got displayed here, porters, admin staff, people who actually we couldn't work without. My MDT are amazing. I'm very lucky to have started at a new centre as a new consultant and have just the best colleagues who are particularly supportive. We work with nearly everyone in the hospital. In bold, I've put the people who I see often in MDT, but I imagine I could feasibly interact with any clinical specialty in the hospital. So the less than best bits, we have to be realistic. Pediatric neuroradiology is tough. Often they are rare conditions and you do have to hit the books or call a friend. My job is particularly diagnostic heavy and I have little patient contact. It works for me, it may not work for everyone, but there are ways to change that slightly. And our workload is forever increasing. We report for the region and people are often quite reliant on imaging for patient management. So it can be difficult to manage maybe patient or even clinician expectations and our forever increasing workload. So my journey, very quickly, I was always going to be a doctor from the early years. I left school at 18 and I went to do medical school at the University of Sheffield and I graduated in 2012, but I actually integrated in a healthcare ethics and law masters at the University of Manchester before that. So I did my foundation years FY1 and FY2 in Leeds. So my FY1 jobs were upper GI surgery, radiology and acute medicine. FY2 was pediatrics, A&E and gastroenterology. And then I joined run through training at Leeds Academy. This is Leeds Academy, this is me, this is Dr. Craven, who, if you've watched anything to do with the BSNR, he's had a lot to do with the education recently. I completed that in 2019, September. I then had a mini gap year in that I took 3 months off to go on holiday. And then I started as a consultant in January 2020 at Queen's Medical Centre. How did I decide to do pediatric neuro? Well, it was this man, that's Dr. Warren. When I was a third year medical student, I was on my neurosurgical job. He was a fellow in Sheffield. He showed me these scans and he compared the extradurals to lemons and the subdurals to bananas. And it all made sense. And that was a pivotal moment for me. I had excellent trainers, that's Stuart Curry, when I was an FY1. He did a lot of teaching with me, and during my registrar years, that's Ian Craven. He was my clinical supervisor and he just inspired me further. So Dan and Ian are both pediatric neuroradiologists and they really, really inspired me during my registrar years. And it often just takes one or two people to be those mentors to you, really. So it was those two for me. I just wanted to end with this, really. When I was looking at funny memes to put in this talk, I came across these word clouds to do with the different specialties out there. The green words are the positive adjectives, blue are neutral, and red are negative. And as you can see, radiology hasn't really got much of a good vibe going for it, really, compared to pediatrics or anesthetics. And actually, some of the words if we make it a bit bigger, are probably inaccurate. It certainly isn't boring or lonely. In fact, sometimes I wish people would just leave me alone so I could get on with my work. It isn't alone or antisocial. So I just thought I'd rewrite that. So let's reconsider it. And I think this is the message that you've heard from a lot of my colleagues today. We're integral. A lot of patients need imaging and a lot of patients pass through radiology. We're collaborative. We work with the clinicians through the hospital. We're dynamic. We know quite a bit. As Rob said initially, we see CT in general radiology and then decide on neuro and then pediatric neuro. So we have a wide breadth of knowledge. We're excellent teachers. You can often get one-on-one teaching with us. We are sociable. I've shown you loads of pictures, and there are further here that show that, we all go out, we're all neuroradiologists in this picture, and some familiar faces from the talks you've had or will go on to have. So that's the end of my talk, and I hope I have just shown you the diverse pathologies that I see as a pediatric neuroradiologist and just how much I love my job. I wouldn't change it for the world. So if there are any questions, I think it's perhaps better to do it as part of the Q&A session in a bit so we can let Rob do his talk. Is that okay?
Yeah, so thank you ever so much for your talk. Obviously a lot in there that I really enjoyed hearing, and some cases that I actually recognise. I think I did see one question pop up in the chat. Just in the interest of time, maybe if you could type response into the chat, or we can save it for the end if there are any other questions. So I am aware that we are running a little bit behind schedule now. This session was due to finish at 1 overall, and we're actually still got one talk to go, which was me talking about sort of academic neuroradiology. So Set, are we okay to go on a little bit longer? Is that all right with you?
Sorry, say that again.
Are you okay if we go on a little bit longer?
Oh yeah, that's fine. Yeah, no.
Okay. So I mean, I can condense my talk down a little bit to maybe keep it down to closer to 10 minutes. I guess anyone who's willing to hang around for a talk about academic neuroradiology is probably a little bit more at the hardcore end of the spectrum, interested in sort of research aspects of neuroimaging and how imaging plays into neuroscience. So I do appreciate that some of you may have to leave, but thank you very much for staying, those of you who are still on the chat. So let me share my slides. So I am an academic neuroradiologist. I'm Professor of Neuroradiology at the University of Nottingham, and as I mentioned earlier, I'm also the current chair of the BSNR academic subcommittee. I just want to give you a quick flavour, really, of what academic neuroradiologists do and how to become one. So yeah, this is really what I want to cover in the next 10 minutes or so. So what do academic neuroradiologists do? Where do we work? And how do you become an academic neuroradiologist? And I just want to say at the very beginning, when I started in my medical career, in fact, I managed to get quite a long way through my my medical career without having a clue about the answer to any of these questions. I really had no idea what academic radiologists do for quite a long time during my training. So I obviously went to medical school, and during my med school I did a bachelor's degree in biochemistry. As a junior doctor, I did adult medicine rotations with some ITU, and I did my MRCP exam. And at this point, I still didn't really know that I wanted to become a radiologist. The thing that actually got me into it was when I was doing a stroke medicine job. I used to, it took so long to get the radiology reports back from the radiologist in those days that I actually used to go down to the scanner with my patients to watch them having their scans, so I could see whether they had a hemorrhage. And I got quite interested in the scanning just by accompanying my patients. So then I managed to get a radiology training post. I did my FRCR, and even at this point, I didn't know I wanted to become a neuroradiologist, and B, I didn't know that I wanted to become an academic. But I started a small research project in about my fourth year with the newly appointed professor of radiology in Nottingham, who was a neuroradiologist, and that project grew into something that I realized it was quite a good project and had the potential to be quite big, interesting. It actually grew into a PhD, which I did in parallel with completing my radiology training. I then got a neuroradiology fellowship and still working on the PhD. I actually went part-time as a neuroradiology fellow, not to do the PhD, but because I'd just had my first son and I wanted to try and keep a bit of work-life balance. But it did have the effect of extending my my clinical training sufficiently that I was able to get the PhD done in largely sort of in my spare time, and some research sessions that the training scheme were kind enough to give me. And when I completed my radiology training, I first got a locum consultant job for around a year in Leicester, and then when the academic post came up at Nottingham, I applied for it, and then worked as an honorary consultant and associate professor for 10 years, and then got a full professorship in a couple of years ago in 2019. So just really wanted to mention that to say, even at this stage, if you're not sort of strongly academic in terms of your aspirations, it could be that down the line you get an opportunity or meet someone who inspires you, and that puts you on the academic track, as it did for me. So what do academic neuroradiologists do? Well, I think compared to other academics in university, the thing about clinical academics is that we retain our clinical practice at the heart of what we do. So first and foremost, I am an NHS doctor, and I work many of the things that you've heard about from other speakers this morning. But in addition, we do lots of other things. I work half-time for the NHS and half-time for the university. And in the half-time of my job, which is university, I mostly undertake research. And I've tried to sort of really summarise what academic neuroradiologists do in terms of research. The three bubbles at the top and the sides. Now, there is no one fixed job description for what academic neuroradiologists do. Everyone has different emphasis to their research, different interests. But broadly speaking, I think you can summarise it into those three things. So imaging to support clinical trials, imaging for improved diagnosis and prognosis for patient care, and imaging to understand mechanisms of disease. Down at the bottom, I put teaching and other random stuff. So teaching is obviously an important part of a university post. But I get dragged into all sorts of other things as part of my job, some of which I really enjoy and find very stimulating, others of which I find a little bit more, sometimes a bit more frustrating, some of the administrative side of things that you're expected to do as a university employee. But overall, I think there's a range of things that you can do in an academic post, which are very fulfilling. Now, one of the things that has come into, I think, every talk today is about the teamwork involved in our clinical jobs, and that's no different for me as a clinical academic. So I work with other neuroradiologists, radiographers, neurosurgeons, neurologists, and so on, and I really enjoy being part of those teams. But the thing about being an academic neuroradiologist is it opens the door to working with a whole load of other people who I wouldn't have been exposed to if I just stayed as an NHS consultant without the sort of academic side to my job. So I get to work extensively with a variety of scientists, neuroscientists, computer scientists, MR physicists. I get to work with people in sort of departments that are sometimes quite far removed from what we do in the hospital, so mathematicians, engineers, and of course I get to interact with a lot of students and postgrad early career researchers, all of which is very stimulating. So I just want to give you a few examples to illustrate those different research themes. These are examples of my own practice, but any academic neuroradiologist, I'm sure, will pull out examples that they've been involved in working on. So classical radiology is where the radiologist looks at a scan and tries to spot signs that point to a diagnosis. And a lot of classical radiology is very well established, but one project that I've been very closely involved with in Nottingham is coming up with new imaging criteria to diagnose multiple sclerosis, particularly in diagnostically challenging cases. And some of you may be aware of this thing, the central vein sign, which is only detectable on imaging use the right sequence, a separate weighted imaging sequence. And there's an example down at the bottom here where you can see a little black stripe surrounded by a slightly brighter. This is a central vein running through a multiple sclerosis lesion. And initially, this was first demonstrated actually using a Nottingham 7 Tesla scanner. Known about on histology, but my colleagues used the 7T in Nottingham back in 2008 to demonstrate this sign. And then there was a whole series of studies that translated this to 3T, showed the specificity, showed that it wasn't dependent on a particular scanner or particular type of screen. And then momentum grew internationally with retrospective analyses from European data sets, international consensus. I only really got involved at about this point in 2016, when I think the team who had been working on this, which was led by Nikos Evangelou, a neurologist, and Peter Morris, an MR physicist, when they realized that if they wanted to translate this clinically, they needed to get the radiologists on board. We're now at the stage where we're doing prospective studies funded by NIHR, and this sign is being increasingly adopted in clinical practice. Artificial intelligence is a big theme now for improving diagnosis and prognosis prognostication using imaging. And I think most radiologists, academic radiologists, are very keen to engage with this. We can see a lot of potential in using it to support diagnosis. And one of the things that we can do is to help the development and testing of AI solutions by helping, for example, to provide curated data for input into the algorithms. But I think another important role for radiologists is actually to really sort of robustly evaluate some of these AI packages in clinical practice, and to do that in a sort of very robust and scientific way, because a lot of claims are made about AI products which have been developed on very sort of refined data sets, but in clinical practice they may not perform so well, and some of the claims I think really need looking at and potentially debunking. And here's an example. A number of groups had looked at using CT scans in patients with intracerebral hemorrhage to try and predict whether the hematoma would expand or to predict the outcome for the patient. And the studies that were in the literature all showed a really high performance from the AI tools in predicting outcomes for patients. But they were all based on relatively small numbers of scans, and often those scans had all come from one scanner in one hospital, which isn't, of course, a good indicator that they perform well in clinical practice. So we took a very large clinical trial data set, TITCH2 trial, which I was the imaging lead for, and we tested some of these radiomic tools and found that although the radiomics, the AI approach can predict outcome in cerebral hemorrhage and can predict hematoma expansion, it really wasn't as good as the published studies showed. And our data set came from 1,700 patients across something like 150 hospitals, I think. So showing that the AI tools, while they work, they're not the magic bullet that I think that's often claimed they are. Another area that I work in is evaluating new technology. So I've already mentioned that we have a 7 Tesla scanner in Nottingham. A number of other centres do around the UK now as well. And you can do some really fancy fMRI type studies. The increased signal that you get from the high field strength allows you to very detailed mapping of cortical areas. We also have a low field scanner, a half Tesla scanner, that's dedicated to research, but it allows you to scan people sitting semi-erect or standing up. And this is actually gives quite nice images for a scanner that's a low field. And this really opens doors to scanning patients who are claustrophobic or scanning load-bearing positions. And we've already heard a lot about the intraoperative MRI. And in Nottingham, our intraoperative MRI is partly funded by the university and has dedicated research time on it. Imaging to support clinical trials. I mean, imaging is often used as an outcome measure for clinical trials, and these are some of the large treatment trials that I've been involved in, where imaging has provided outcome measures for the clinical trial. But I think it's also worth remembering that imaging can be used more than as just an outcome measure. It can actually be used to guide targeted treatment trials. And this is an example of a feasibility study which we're currently doing. I've got a long-standing interest in using imaging to understand cognition in patients with multiple sclerosis. And we've previously used functional MRI to show that that connectivity within a particular circuit in the brain appears to be related to cognitive performance. And this gives us a potential target for interacting using neuromodulation. So here, transcranial magnetic stimulation can be used to modulate this circuit. And this is an example of a setup that we've recently purchased where we're going to be using TMS to try and modulate cognitive function in MS. But critically, we're using the imaging to guide the treatment, not just to show us the anatomy of where we're stimulating, but also we're going to be using the individualized connectivity pattern in patients to guide the exact location that we're going to stimulate. Just an example of where we can use imaging to understand the mechanisms of disease. This is also in terms of cognition in MS. We've been using functional MRI, people with MS, to allow us to define a number of whole brain networks using a technique called graph theory. Graph theory is a way we can describe networks or network properties numerically, and there are lots of different measures you can get of network properties: clustering coefficient, modularity, small worldedness. I won't go into the detail of how it works, but there's some sort of you take your functional MRI images and your anatomical images, and you do some clever processing. And at the end of it, you get out these measures, which you can then compare between patient groups, or you can correlate with cognitive performance. And what we found is that what we found is that there were some quite striking differences in these network measures between people with MS, with cognitive impairment, and people and healthy volunteers. And not only find group differences, we also found that they correlated pretty well with the cognitive performance. So understanding network properties can help us to sort of understand real world problems that the patients experience with cognition. Okay, so just about some of the other things that I do. Teaching is obviously an important part. Now, there isn't a huge amount of radiology teaching directly in many undergraduate medical courses, but I do get to teach a lot in other courses. So in for example, psychology or neuroscience master's courses that we have at Nottingham. I also get involved in various public engagement events, which I enjoy. And there are other ways that we've sort of done public engagement. For example, a few years ago, we developed an animation to help prepare children for MRI scanning. It's only 3 minute long, nice little cartoon to explain the procedure, but that's now had, I think, close to 500,000 views on YouTube, and something I'm proud with. I get to do what I put here as proper science. So, questions that I've started off asking from an imager's perspective have led me into to worlds of science that I never really knew existed, but now I'm involved in projects that no longer have imaging in them. So, for example, we're currently looking at the transcriptomics of cerebellar development. It arose from an imaging project, but now I'm working with people who are looking at it, and the imaging has kind of actually dropped out of the project, but I'm still fascinated by the science. And I'm involved in developing various practice guidelines, which sort of draw on my academic skills, but are not necessarily areas that we're actively researching. Now, in the last minute or so, I just quickly want to talk about academic training, because a lot has changed since I went through it. Some of you may be familiar with the integrated academic training pathway. And in the obviously, normally what you do after medical school is you pass through foundation training, specialist training to become a consultant. And about sort of 12 or 13 years ago, the integrated academic training pathway was put in place to provide what should be a sort of seamless pathway for academics through the academic foundation program, clinical academic fellowship, clinical lectureship, onto an academic consultant post. And typically with a PhD falling somewhere between the academic fellowship and the clinical lecturer post. Now, in reality, very few people pass through this, sort of go through every step of this. And often we find people come into an ACF having not done an academic foundation program, They may, for example, do a PhD and actually then not do a clinical lectureship. They may continue their clinical training, and then at a later date get an academic post. There are some people who do a PhD without having done an academic fellowship. You know, they may just see an opportunity may arise to do a PhD, and they may step out of clinical training to do that, and actually bypass all of these other posts before coming back into academia at a later stage. There are also many people who stay as an NHS consultant but get an honorary academic post during their consultant position. Sometimes you do find people do a PhD earlier on, maybe after their academic foundation program. Some people even come into medical school, you know, having already completed a PhD. And then finally, I think it's worth bearing in mind that although you know, this was set up as a pathway to generate academics, there are people who do one of these posts and actually find that academia isn't for them and just revert back to clinical training. Tilak mentioned he did his ACF and then went back into clinical training and a clinical consultant post, and that's absolutely fine. You know, it's not what everyone wants out of a career. So some people you know, try it and back to full-time clinical practice. So that's a very, very quick run through. I've sort of condensed it as much as I can, but just really to mention that, you know, I hope I've shown you that academic neuroradiology is truly multifaceted and highly collaborative. I find it endlessly fascinating that you can explore lots and lots of different areas. And you know, it's a career that, although there is this defined integrated academic pathway, actually there's lots and lots of different routes in and out of it, with options to complete clinical training and come back into academia at a later date if you get the opportunity and have the appetite to do so. So thank you ever so much for listening. I'm going to stop sharing. If anyone has any questions about the academic presentation or any questions at all from the whole morning's talks, then please do feel free to put them to us. I can see a few of the speakers still online. So let's have a look. So in the chat, I can see I'll answer the question from Asad. Any other thoughts or questions anyone might have? Okay, well, look, if you do have any questions, feel free to send them in to, well, I guess, can they send any questions to NANSIG for forwarding on if anyone has any?
Yeah, so yeah, if anyone has any questions, feel free to email it to NANSIG, and then if it's, I mean, if it's sort of NANSIG related, then we can reply to it. Otherwise, we can forward it to yourselves, I mean, to the speakers, to the speakers, if you guys are happy for us to email you.
Absolutely, yeah, wonderful. Okay, well, it feels like lunchtime for me, so thank you ever so much everyone for joining today. I would once again like to thank all the speakers. I really enjoyed hearing everyone talk. I thought they were fantastic set of talks, really giving you a feel for what neuroradiology involves. Thank you to NANSIG for inviting us to talk today. It's been great being here.
Oh, thanks a lot, Rob. And yeah, and from NANSIG as well, thank you to all the speakers for all your inspiring talks. I think, or at least for myself today, I think I've really learned a lot about radiology and neuroradiology. And you know what made you guys go into the field and all of the exciting cases that you've seen today as well. So definitely a lot to take home from it.
Okay, wonderful. Thanks ever so much then.
Cool. All right. Yeah. Thank you, everyone.
Thanks. Bye-bye.
Bye-bye.